A very good evening and a warm welcome to one and all present here. I am Bibulina from Clearnet. We are very much proud to be a part of this webinar as a digital partner. So with all your permission, now I am going to play a short video of Clearnet. Thank you so much, all the doctors, for your patience. Our website is www.clinic.com. You all are invited to visit our website. So now, without further delay, I would just a minute like to welcome Dr. Aradhana Gupta, ma'am, who is Director and Senior Consultant IVF Specialist associated with Aradhana Test Tube Baby Center, Bhopal. So, ma'am, now it is over to you to start with our today's program.
Thanks for all your praise and kind words. A very good evening to all. I would like to bid you all. I can see many stalwarts of this field, and there are Dr. Anju Soni, Dr. Vipasha Sen, our own president, Dr. Sashi ma'am, and esteemed faculty. I welcome you all to this conference, which is a unique in the way like addressing about the vulvar diseases is not so common topic, but we all know that it's quite common in our OPD. I am really sure that we have a very good, we will be when we will come out of this conference. And without further ado, let me now take the privilege to introduce our very humble president of Bhopal Menopause Society. She's an eminent gynecologist and obstetrician known for her exceptional work, ethics, professionalism, passion, and excellent people skill, Dr. Shashi Srivastava ma'am. She is the director and consultant of Saurav Nursing Home for last 37 years and a life member of many society like PMPA, IMS, PCOS, Foxy. And top of it, she is a very down-to-earth personality and she is very dear to all of us. Dr. Shashi ma'am, please enlighten us with your welcome speech.
Thank you, Aradhana.
Over to you, Dr. Shashi ma'am.
Okay, thank you. It is my pleasure to welcome all office bearers, faculties, respected dignitaries, and delegates from the heart of the city, the lake of cities, Bhopal. A warm welcome, our President, Dr. Shobna Mohandas. I appreciate for her far-sightedness, providing a platform to all members of IMS to gather a knowledge on the various aspects of menopause by the eminent faculties from all over India. I feel honored to welcome our guest of honor, Dr. Seema Sharma, Dr. Vipasha Sen. It is my privilege to welcome and introduce our Chief Guest and Secretary General of Dr. Anju Soni, the charming lady with vibrant personality. Dr. Anju Soni has done her MS Gynae, MS FICOG, FICMCH, CIMP. Her area of interest are high-risk pregnancy, critical care gynae, minimal invasive surgery, and urogynecology, menopause, and Yog Vidya. Currently, she is a chairperson of HIV and AIDS Committee 2022 to 23, Secretary General IMS 22 to 23.
Thank you so much for your kind introduction. Let's not go waste time.
No, madam, please shower your blessing to all of us. We are waiting for your
First of all, I am thankful to you and Dr. Shobna for involving me in this beautiful webinar of Bhopal in the Menopause Society, and you have just taken over, and we can see the enthusiasm which you are working, and all your team members from Bhopal and all other delegates who have joined. And I'm thankful to Dr. Ambuja also, and my dear friend Vipasha and Seema, all for all being here today. Whenever we talk of vulvodynia, I think it is one of the most complex problems we all know of. It has basically, it's basically an unexplained pain around the area of vagina, and the vulvodynia can be very, very uncomfortable for the woman, and and sometimes becomes unbearable, such as sitting or having sex. And it is very common and rarely diagnosed condition. It is seen in more than 1 million cases. Even in India, it has been found. And that we all know treatment can help, but the condition cannot be cured. And it requires, the most important thing is it requires medical diagnosis, lab test, and are not needed. And then imaging is also rarely required. Of course, it can resolve within months. Also, what is more is that the diagnosis has to be done after excluding all other problems, like and it includes burning, rawness in the genital area. It may be constant also. So pain in this area, and when there we cannot find any other cause, including the painful coitus, especially there can be vaginal dryness, vaginal itching, and inflammation. And we have to sometimes treatment includes avoiding irritants and tight clothings and perfumes and dyes in that area, and self-care is avoiding irritants and hygiene, local anesthetics and pain medications, and biofeedback therapies and medical procedures such as nerve block may be required. And we all know that this complex problem which Dr. Shobna has chosen will definitely benefit each and every person who will be joining, because though in foreign countries there are primary care providers and physiotherapists also involved in this stage, but in our country, at primary level, OBGYN doctors especially, we are there at forefront. So we need to diagnose and treat this problem, uh, and manage it at our level. And my best wishes and congratulations to Dr. Shobna and Bhopal Menopause Society for taking over this important and yet not fully understood topic, which I'm sure will benefit each and every person today who is there, who is attending this webinar. Thank you very much for making me a part of this webinar.
Thank you, ma'am. So now, with the permission of all the faculty, I would now start the academic session with the introduction of our
Sorry,
guest.
madam, please invite Dr. Bipasa Sen and Seema Sharma to give their words of introduction.
Dr. Seema Sharma and Dr. Vipasha Sen, whose success speaks for them. They are the living idiom of the women who happen to be at epitome of the success, which is the result of the consistent hard work and perseverance. Dr. Seema Sharma, she is a professor and head of the Department of Obs and Gynae, JNU Medical College, Jaipur, and Vice President-elect IMS, member of ASHRAE, which is a well-known society, has been Vice President JOGS, Vice President Rajasthan Branch Narchi, and the Chairman IMS Examination Committee, Editor Indian Journal of Obs and Gynae, and she's a Director Sankalp Gynae Care, speaker for over 200 invited lectures. So she has a lot of accolades in her CV, national, international.
Thank you, Doctor. I think that is enough uh, for
She's
my introduction.
member of various journals of Obs and Gynae. Dr. Vipasha Sen, she is a consultant gynecologist and treasurer, Indian Menopause Society. She is secretary, Public Awareness and Community Services Committee, Bengal Obs and Gynae Society. She is a treasurer. She is past treasurer, Indian Menopause Society, treasurer, South Asian Federation of Menopause Society, secretary, Indian Menopause Society, Kolkata chapter, organizing secretary, East Zone, Indian Menopause Society Conference, and faculty at various national and international conferences, academic meet at Canada, Czech Republic, Pakistan, and Bangladesh. I request you both to kindly say a few words of wisdom and address the gathering. Thank you, ma'am. Over to you.
Thank you, Dr. Anuradha, and I must congratulate our president, Dr. Shobna Mohandas, who has arranged these webinar in a so arranged fashion that all the important topics and all the neglected topics which are of importance in our day-to-day practice, they are all taken up. And weekly we are having an academic feast particularly related to menopausal topics. So this is a very important and good thing this year, which is carried out with the whole of year for it. And today's topic is also very sensitive topic for women because it is very important to correctly diagnose the causes of vulvodynia, because it is a condition for which women suffers, and they particularly they themselves are not able to express what problem they are having, and many times we are also not able to easily diagnose the etiology. So with these deliberations, I suppose we will be having a good discussion in a right direction to having a management of these cases. Thank you. You are
Vipasa,
welcome,
unmute
Dr.
yourself.
Desai.
Vipasa, unmute. Unmute, Vipasa.
Hello. Good afternoon, everybody. First of all, I am thankful to our president, Dr. Shobna Mohandas, and also to Bhopal Menopause Society for involving me in such a good session. And Shobna has really arranged this series of webinars every Tuesday in such a way that many previously neglected topics are being discussed, and which are need of the hour. And I really feel very, privileged to be a part of this thing. And I am eager to listen to all the speakers, so I cannot waste much time. Only I want to share one thing. When I was a student of medical college, Calcutta Medical College, in my student life, two of my classmates, lady classmates, they didn't know not vulvodynia. One had vulval wart somehow, and one had some vulvitis. So, but they went on suffering and suffering. They didn't even disclose it to us, to our friends, lady friends. They didn't disclose. Only when things went beyond tolerance, they told it to us. Immediately we got advice from our gynecologist, lady gynecologist, of course. In if this is the scenario in a prime medical college in a metro city, among the medical student, we can imagine what is the problem, how women of rural area or common people, they go on tolerating all these things. So what I feel, apart from these discussions, we should let them know from through some public program and all, that we are here for you. And I think today's speakers will address all these issues. I am eagerly waiting for this, and all my best wishes to Bhopal Menopause Society and today's webinar. Thank you.
Thank you, ma'am. We are blessed to have you here, and thanks for your enlightening words also. Now, let's start our first talk on a very important topic, vulvodynia. And for that, I would now like to take the privilege of inviting our person of our first session, Dr. Sarla Jain. She is a woman who needs no introduction. Our past president, Bhopal Menopause Society. She is MBBS, DGO, CMS, MP, FICOG. She is practicing since last 40 years in Bhopal, and she is a life member of APMP, FOXY, IMS, ISAR, PCOS, and MP, AMPOG. She has been successfully organized West Zone Conference of IMS in 2019. Dr. Manisha Khare, she is our second chairperson. She is another example of women empowerment and a role model for many women. Dr. Manisha Khare is a renowned gynecologist of Bhopal. She is the director and chief consultant at Manisha Hospital, and she is a visiting faculty for the various MP government departments. She is a former president of BOX, means Bhopal Obs and Gynae Society, vice president MPOX, and the life member of Bhopal Menopause Society and has organized many health awareness camps. She is very humble by nature. She is very dear to us and won national award for President Best Branch PM Surakshit Matratva Abhiyan. She has been serving patients in Bhopal and nearby areas since last 30 plus years. Her dedication towards helping patients and constant efforts to remain updated with advancement in gynecology have contributed in her popularity among patients. Welcome, Manisha ma'am. Dr. Meenakshi Patel, she's a well-respected and well-known senior eminent gynecologist of Bhopal, former President Box, founder secretary of AMPOX, organizing secretary of various conferences, and has attended several conferences as faculty. I welcome all our chairperson and request to start the session. Over to you, ma'am.
Shall I start the talk with the permission of chairpersons?
Yes, ma'am. Sarah Didi, you're muted.
Hello. Hello.
Yes, ma'am. Yes, ma'am.
Good evening to you all, faculties and delegates. Today I got golden opportunity to introduce our dashing president, Dr. Shobna Mohandas. She is MD, DGO, FICOG, Diploma in Endoscopy.
Madam, I'm introduced every week, so now we will leave that, madam.
Okay. So now over to Dr. Shobna.
Okay. Thank you, ma'am. Thank you for working hard. By the way, I would like to clarify that this session is on vulval cancer. Although I chose to spoke on vulvodynia and the next talk is on chronic fungal infections. Actually, Madurai chapter is doing the vulval diseases part. That will be done on 13th. This session is basically on vulval cancers, and we have a whole lot of oncologists sitting there to talk to us about vulval cancer actually. So we will finish with vulvodynia and chronic fungal disease, but the most important session is on cancers, for God's sake, and that's going to come because Bhopal told me, no, madam, we've got so many cancers and we have got so many cases. We want to discuss cancer, not vulval disorders, and that's what will be discussed later. But before that, I'll just finish this vexing topic called vulvodynia. I bring you greetings from my hospital and Thrissur, the land of Purams. You know what? Vulval diseases is vulvodynia is actually vulval pain not related to any specific identifiable disorder. And the patients will come with constant pain, sexual intercourse pain, painful, can't even sit anywhere for long. Can you imagine? You can't sit in a flight, train, anywhere. And painful tampon insertion, pain wearing pants, irritation, burning, and that all that is there. And when you look at the patient, if you have atrophic vaginitis or a carbuncle or a herpes simplex or some swelling, you're all happy. You can treat it. If you can't treat it, what do? Then it is vulvodynia, and then you have to worry. So you have to examine the patient, even if you don't find anything clean, neat, vulva. You just touch and find out if it's a localized pain. Sometimes it won't be localized. It's all over, the patient says, and you don't know what to do. And these things can come just because of embryologic development. For God's sake, why it didn't come till the age 50? All this time embryo was still there, but it is coming only now. Increased urinary oxalate excretion, genetic or immune factors which makes you sore and stiff at the age of 50, neuropathies, they're all there. Let's think of the modifiable factors. If you are born embryologically, all that, you can't change it. What we can change is, suppose it is an oxalate deficiency, then you can keep oxalate 2 to 4 tablets daily, calcium oxalate or something like that. And look at the particular calcium content which contains oxalate and you give 2 to 4 tablets. Or avoid tea, chocolate, orange juice, grape juice, eggplant, cucumber, spinach, tomato juice. No, stupid things that we normally take, we don't think that it can cause pain. So if a woman comes with pain, imagine you look back on the presentation, look back into the internet, and then tell her to come back one day later and look at what causes pain. It really helps. That's what they say. A low-fat diet, reduced intake of vitamin C. Why? That's why that all that tomato juice and orange juice and all comes in. Reduce sodium intake. We all have that khara khao, khara khao. Drink plenty of water. Supplement your diet with high complex carbohydrates, opposite to diabetes. And low protein, opposite to your dieting. Eat more potassium-rich fruits and vegetables. So these are all very important because we normally say the opposite things to a patient for reduction in weight. No soap on the vulva, 100% cotton pads, lubrication for intercourse, and rinse and dry vulva after urination. The problem is vulvodynia causes psychological problems because everybody looks at the vulva and says, oh, nothing is wrong with you. Something is wrong with your brain. And that increases the pain and the vicious cycle starts, Progressive increased activity of the dorsal horns of the spinal cord after repetitive activation of the primary nerves coming from the vulva. So the brain starts getting stimulated more and more because every time the stimulus comes here, so then the vulvodynia becomes a neural problem. That's how it happens. Can be because of fibromyalgia, localized pain. Regional pain syndromes can also stimulate with the irritable bowel syndrome, tension, all that can also happen. Psychiatric disorders also can come. Now, when all this comes and then you really say it is only vulvodynia, everybody wants pills for everything. So you start with pills first. Venlafaxine, you start with 3.37.5, increase to 75, then to 150. Gabapentin, 300 daily, and increasing every 5 days by 300. And even you can give up to 303 times daily. We gynecologists don't have the guts to give that much, but you may have to give it that much. So everybody wants pills. Nobody's going to tell you if they like you. You tell them don't eat tomato, brinjal and everything. They will like it if you go and give them pills. Paroxetine, it decreases the neuronal hypersensitivity. It is 10 milligram daily or go up to 20 to 60 milligram daily. Amitriptyline, 25 milligram at bedtime, so on. So drug therapy is there for this illness. Only thing we are not prescribing it every day, so it's not by heart for us. Tramadol, effective for long-term pain management in the elderly population, 50 to 100 milligram orally every 4 to 6 hours. That's also a very high dose. We max to max, we give 50 milligram daily. But imagine giving it every 4 to 6 hours. But this is what they are saying in the books. You can give it such high doses. I don't know if they will get so tired after eating so much of tramadol, but this is given in the books. Okay. Now, if that doesn't work, or if you don't want to give the such drugs in such heavy doses where the patient gets tired, what you can do is you put a lignocaine topical gel 2% 30 minutes before sex. It interrupts the painful impulses and minimizes the feedback amplification of pain and allows for healing. You apply a copious amount of 5% ointment to the affected area as bedtime. Place a cotton ball generously coated with the ointment in the vestibule and use it nightly for 8 or more hours every night. If your drugs, this can be tried, There is something called trigger points. That is when you have, some hyper irritable spots are there in the body, which are taut bands of skeletal muscle or fascia, which are painful on compression. So when you touch that area, you will have pain. It will produce a pain which is referred to other parts also. This can be because of direct trauma, joint hypermobility, previous surgeries, or poor posture, or static exertion of the muscle. You pull on something or you push on something, you sit somewhere, you jump somewhere, you don't realize it. And then there is a trigger point started and it goes on and increasing. Deficiencies of vitamins and folic acid can increase it. Vitamin C, D, iron, magnesium, zinc, all deficiencies will increase it because everybody does all this by mistake, falling down, by mistake doing that. But if you're also deficient in all this, then it will be worse. So in these patients, there is a higher concentration of bradykinin, GCR, PTNF alpha, and all that will cause a presence of local ischemia and sustained release of ACH. There is a vicious cycle. Spasm gives pain, pain will release C fibers, and that will release the substances that will stimulate the mast cells. It will cause further damage of the tissues and that spasm increases and then it becomes a vicious cycle. So you have to break this vicious cycle somewhere. You know what? In the vulva, what it does, if these trigger points are in the bulbocavernous or ischio-cavernous muscle, you will get dyspareunia or pain with organism or clitoral pain. If it is in the transversus perineum, only dyspareunia. Anal sphincter will go burning and tingling in anus and proctalgia. Patient can't even sit all the time. Pain is there, you know. Deep muscle layers, of course, it's not vulvodynia strictly, but urinary urgency and frequency pain of urination and everything can be there if the anterior part of the levator hand is done. The posterior part is there, then defecation is affected. So these small things we don't think of as gynecologists. Even coccygeus, obturator, internus, piriformis, all this can be affected. But we are now with the vulvodynia. So you palpate the vagina properly everywhere. Look if there are taut bands, possible trigger points or anything. This is after your drug treatment has failed, your lignocaine treatment has failed, and then you try to find those trigger points. And once you find those trigger points, you can either give physical therapy. You just go on rubbing, and then along with that give medication. Otherwise, then you inject those areas. This giving physiotherapy is not for you and me, because you have to ask the patient to contract, relax technique, followed by a prolonged stretch. You stretch it, then ask her to contract and relax. Takes a lot of time, It requires techniques, and so only the physiotherapists can do it, and they should spend a lot of time with the patient. Foam rollers and physio balls and everything is required for all this. You and me can't do it, but if the patient herself can do it, maybe it will be useful. Foam rollers will be available on Amazon. What you and me can do is trigger point injections. Mix 2 ml of xylocaine in 1 ampule of 100 ml and 1 ampule of hydrocortisone with distilled water to make 20 ml. Load in a 20 ml syringe and find out where the point is. Inject 2 ml into the painful areas in the vagina. That will release it and it remains permanently gone. It's not just temporary at that point of time. It goes off. Or you can just after, you can take some betamethasone lignocaine. You can give it at previous surgical site of vulva, episiotomy or vaginal hysterectomy with periotomy is there. Wherever that is causing pain, those places also you can inject it at several points, 25 gauge needles. It will block the transmission of C fibers, which are responsible for pain sensation. Side effects, transient exacerbation of pain will be there. Some of my patients had vasovagal syncope, but they recovered very fast. Vaginal hematoma has been described. I have not seen it. Another thing what they are saying is if there is a periurethral problem, you rule out infection properly, because otherwise it will spread. If there is no infection, no caruncle, everything you have to rule out, give enough antibiotics and everything. After that, we give 4 to 5 cc of bupivacaine or triamcinolone bilaterally with one finger in the vaginal canal for guidance, and it will help your patients. Pudendal neuralgia is another problem. The nerves of the pudendal nerve connect so many places, and the pain is expressed in the anatomical area of the pudendal nerve. Pain is aggravated by sitting. Patient does not wake up during night due to absence of nocturnal pain. That is there. So that will rule out other things. There is no objective sensory loss on clinical examination, and there is a positive response to anesthetic block of the pudendal nerve. We all give pudendal blocks while giving a vacuum delivery and forceps delivery. We are also expert at that. So you give your pudendal block and the patient is relieved. So these big patients who are suffering, you can just try it out for want of nothing else. Even that is possible. So pudendal neuralgia may be also treated with behavioral modifications, physiotherapy, analgesics, and nerve decompression. Now, there are people who give botulinum toxin injections. That's very costly. It has got a temporary paralytic effect on the surrounding skeletal muscles, as skeletal muscle hypertonicity is the cause of the problem. It also modulates the neuropeptides and neurotransmitters. So what do? 10 units of botulinum toxin A. It's a very costly drug. It was injected into the muscles of the perineal body at 2 sites. See this. What is Botox? It is a product of the anaerobic bacterium Clostridium botulinum with antigenic properties. It binds to nerve endings, this bacterium, preventing the secretion of acetylcholine, and this causes neuromuscular blockages and muscle paralysis. So it is, if it is injected into the anal sphincter, it creates a temporary chemical denervation, and injection into the levator. All this is possible. So, and the effect lasts for 16 weeks. See, these are the 2 points where they have injected the botulinum toxin for vulvodynia. Now, if that also doesn't work, then you have to go in for surgery. You actually palpate and find out which are the painful areas. And then you make a U-shaped incision starting from the periurethral area, encompassing the laterally the heart line, medially just inside the hymenal ring, and posteriorly the superior portion of the perineum. The skin, mucous membrane, hymen, and adjacent tissues are removed, and the vagina is undermined, mobilized, and brought down to cover the defect. The closure should occur in 2 layers using absorbable 3 and 4-0 sutures. And in addition, one thing you have to remember, it's not indicated for women with generalized pain, So this is how they do it. You just cut that skin, cut it nicely, and resuture it. So that is the next step after botulinum toxin doesn't work or your trigger points do not work. So you have other things to do also. So besides all this, please look out for your herpes. I have a patient who, even without examining, if I find it is herpes simplex, in the dark area of your OPD, even if you shine a torch, you won't be able to see small herpetic simplex lesions, and you can use acyclovir. I give 400 milligram 1 TID for 2 weeks. If that doesn't work, I give Valsivir. The dose given here is 500 BD, but generally you have to give 1 gram BD, and it has to be given for 7 to 10 days. In very severe patients, even Valsivir 1 gram TID is necessary. But 80% of my patients, they do respond to acyclovir 400 TID. Only once in a while, I have to give this Valcyclovir. That is it. I had gone to give this talk on pelvic pain basically in Chennai, and one doctor came to me and said, doctor, I had a friend who found that this vulvodynia was there, and she did cytology, and she found it was in situ cancer cervix. And what she did, she gave that anti-condyloma drugs, imidomidone or something like that. It's there. In our times, it was just podofil. Now that new drug is a imidomacin or something like that. And because VIA and CA cervix is caused by condyloma acuminatum, that doctor gave that drug for a long time, and that patient got cured. So these are just thought processes that make science. So what other people are trying out in one patient will become a cohort study, and then becomes a case study. Then it becomes a meta-analysis and all that. So the first thought process is that you have to treat the viral infections either with your acyclovir or your anti-HPV drugs. So you can even try all that and rule out infections before you call the patient a patient of vulvodynia, where you can't see any other cause. You can even think of neuralgias, give injections. And so with that, I will just stop my talk, and thank you for your patient listening. I have not taken very long. I'm so sorry. I think we will have a lot of time discussing vulval cancer. So there is a lot of time given for the esteemed panelists who will be talking to us on vulval cancer. I'm sure the audience is waiting for that also. Over to you,
Madam.
Chairpersons.
Yeah, Madam, thank you very much for the enlightening talk. The talk was excellent. I'm supposed to take the questions, but I can see only the messages which I can see is good evening, and Dr. Sarla.
Forget all that, madam. If there are no questions, we won't waste time.
There are no more questions I could see.
If anybody in the audience want to tell us their experiences, they are welcome.
Dr. Shobana, I have got one thing.
Yes,
see, have you ever used this botulinum toxin?
No, madam. No, madam. I have not used botulinum toxin. I have only read of it.
Long acting, no. If you give some experience on that, we can.
I'm sorry, I do not have personal experience. Trigger point injections with xylocaine I have given. Otherwise, botulinum toxin I have not given.
I have tried steroids, betamethasone. That
Yeah,
works
that
well.
even I have tried, madam. Where
Ah.
have you given, madam? Please give us your experience on with steroid.
Steroid, definitely it helps a lot. But only thing is
How
that
many
I will,
injections, madam? They're saying weekly 6 injections and all. How many have you given?
no, I have given just alternate days.
I just
Okay.
give one injection, that's it, and that is gone forever. Whatever trigger points I give, just 2 millimeter, and they come years later also, there is no pain. That is my effect. But you are saying you're just giving steroid, you're not adding water or you're not adding distilled water, nothing. You only give steroids.
Yes, yes.
Okay. Anybody else has got experiences to share on vulvodynia? Unusual cases? Sushma Chala, madam, is the senior person. Do you have any cases, madam? From Ludhiana? Madam, please unmute yourself, madam. Madam, please unmute yourself, madam. Yes, from Jalandhar she is.
No, not many patients, but one patient from Germany came to me with this. And I think for 8 years, they never had any contact because of this thing. So all psychological problems were sorted out. Then ultimately just taught them with the xylocaine and all. So I think it was more of apprehension and psychological problem. Sorry, I joined late. I didn't really attend
No, madam.
it must
Anju
have been
Soni
very
has got
good.
a patient of hers who is a very dear friend of hers, no?
Yes.
Thank you.
Dr.
Anju, you
Shobna,
had a patient, you were discussing that in the other conference, Anju.
Dr. Shobna, which steroid are you using?
I just use hydrocortisone 100 milligram, 2 cc xylocaine, and fill the whole syringe with distilled water.
Okay. Only once?
Yes, I even use it for cesarean patients. After cesarean, they have pain. After 6 months also, it's not going off. Even pelvic infection on the abdomen also, I use trigger point injections. Find out the point, go under the skin and inject into the painful areas without going beyond the subcute.
Okay, thank you. Thank you.
It's very effective and it works even on the abdomen.
Ma'am, I had a patient post cystectomy. She had pain around perineum, and there was nothing. We had given antifungal and then creams and all sort of the things, but she could not relieve of her pain. And she was every time like after hysterectomy, still I'm having pain and like that. She had come from other source. Then I was really I could not help her out because there was nothing which I can say like there is this problem is causing pain. So I think what you have said that injection of hydrocortisone with lidocaine might give a relief for such patients, which is like invisible lesion. I don't know, maybe some
we can
very
try
sensitive
it out.
area.
Yes, yes. Okay then. Okay, over to the chairpersons. Third chairperson is there. They finished.
Meenakshi Didi?
Meenakshi.
Okay, then you can take over and.
So let's
Hello,
start.
can you hear me?
Yeah.
Can you hear me?
Yeah, ma'am.
Hello.
We can hear you. Yeah, ma'am.
So the subject has been very well covered up by Dr. Shobna, and we all know about vulvodynia, and we frequently get the patients. Mild cases are more frequent with us. Diagnosis
Ma'am, your
is
internet is
important.
And your voice is breaking.
Already said. Treatment it depends upon how what type of pain the patient has as it has appeared. So the treatment has been very nicely covered up by Dr. Shobna.
I think she's breaking.
Yeah.
Somebody has asked whether, again, she has asked whether you should give local steroid injections. It's not just steroids. It's the question of injecting some fluid to disperse the fibers.
Okay.
So it contains steroid with xylocaine to differentiate, not have
They're
pain
very
while
important.
injecting. So it's not the steroid that is acting, it's the act of giving the fluid around that painful area.
Then how much, I mean, how is it like, normally it is 2 ml when you dilute?
No, I
Okay, thank
told
you,
you again,
Dr.
I
Shobna,
told you
for
20
this.
ml
We discussed
with
in
1
detail with you.
ampule of
Thank you so
hydrocortisone and
much.
2 ml of acyclovir. Total 20 ml is what I give. Out of that, all of it need not be injected, 2 ml into painful areas. Rest of the area, you may even throw out the remaining solution. Because it's not necessary to inject all of the 20 ml. Okay.
One
Over to you, MOC. Madam, please start the second session.
Aradhana, you're muted.
How frequently?
So now I start with the second part of this first session. The second talk of first session is on very important topic, chronic fungal infection of vulva, which will be delivered by Dr. Sashivala Bhosle. Her lovable name is Pam. We all know her by this name. And for that, I would like to invite chairpersons. First of all, thanks everyone for sharing your immense treasure of knowledge with us. And it was indeed very informative and enlightening talk. Ma'am, you were brilliant, and we have become wiser with this brilliant talk. Moving forward with the session, now I would like to invite 3 prominent ladies who have established themselves as women of virtue and simplicity and are epitome of sheer living inspiration. Dr. Priya Bhavi Chitawar, she's a consultant and head of the Department of Reproductive Medicine, Bansal Hospital, Bhopal. FNP Reproductive Medicine teacher, ex-faculty DM Reproductive Medicine, and Foxy recognized trainer in basic and advanced infertility management course, and Cochrane reviewer and author. She is a reproductive medicine specialist who has been trained in one of the best institutes of India, CMC Vellore, and she has expertise in reproductive medicine and minimally invasive reproductive surgery. Second is again Dr. Rajni Hajela. She is currently treasurer of the Menopause Society Bhopal, and she has done MD from prestigious King George Medical College, Lucknow. She has worked as consultant obstetrician gynecologist at Second March Hospital, Sebha, Libya, Razi Hospital, Sarwan, Iran for almost 11 years. It's a vast experience. After returning from abroad, she is working as consultant obstetrician and gynecologist at Hajila Hospital, Bhopal. Hajila Hospital is recognized for high-risk pregnancy and assisted reproductive techniques. Third, she is a brilliant beauty with brain, Dr. Anjali Kanade. She is MBBS MD, FICOG, FAIMER Fellow, GSMC Mumbai, ACME, Professor and Head, Department of Obs and Gynae, Chirayu Medical College and Hospital, Bhopal, and the President of Obs and Gynae Society, 21 to 22, means last session. She's one of the best gynecologists of Bhopal, rich in academics, and has been the recipient of Dr. Jagdeshwari Mishra Best Poster Presentation Award for 3 consecutive years. And her work in high risk pregnancy medical education is commendable. She's a very good teacher, I must say. So I would like to say a few words by the chairperson and introduce our next speaker. Thank you. Welcome you all.
Very good evening, everybody. With the permission of my co-chairpersons, I would like to introduce Dr. Shashibala Bhosle. She does not need any introduction. She is the dynamic president of the Gwalior Obstetric Gynae Society and has got a lot of work in the Department of Public Health and Family Welfare. She is the member of IEC Committee Foxy 2122 and is the coordinator of IEC Committee Rajyog Foxy. She is the in charge of Mercy Home under Gwalior Mansik Arogya Shala for 8 years with and has worked with the mentally challenged children. She is director at the Fight Back Warriors, dedicated to the women empowerment through women self-defense. She is the co-founder and in-house medical advisor for the maternity wellness firm Just Conceived, founded in 2019. She is also an active member of IMA and IFS, along with her work as the president of Gwalior Obstetric Gynae Society. She is also the member of Society for Empowerment, an NGO from Patna. Madam would be giving a lecture on the chronic fungal infections of the vulva, and I would like to invite her to give a deliberation on this very important topic.
Thank you so much. And I'm so glad to be in the august company of all you IMS members, and especially Dr. Shobna. I was listening to your talk and I was really so many new things to learn in each and every conference, and you had really given real. So I feel my chronic fungal infections is just a revision and everyone knows about it. And I'm glad Dr. Shashi Srivastava invited me to be as a speaker. So without wasting any time, I'll just start with that. Now, chronic fungal infections. We have been taught far more about shame than about anatomy. So Lynn Enright, Vagina Re-Education, he says, women tend to ignore and hide vaginal vulval problems. So we have to have elicit a typical history. So chronic fungal infections can be very irritating. And can I have the next slide, please? So introduction, most common vulvar skin conditions, as madam has already said, they are mostly associated with inflammation, like contact dermatitis, lichen simplex, chronic lichen sclerosis, lichen planus, and other vulvovaginal disorders like vaginitis, vulval, low-grade, squamous intraepithelial lesions, which we'll be discussing in the panel, and vulvar high-grade squamous. So that is the main attraction of this vulvar study today. And vulval atrophy and vulvar play pain has already been touched upon by Dr. Shobna. Next, please. So vulvar skin disorders, as they say, include a variety of inflammatory conditions of the vulva that may also affect the extragenital area. So pruritus and pain, just so irritating. The patient will come without wasting any time. At whatever time, they just rush to us and tell us that these are the presenting symptoms, and they are often chronic, and then they get acute because of the scratching and can adversely affect our sexual function and cells of well-being. So they are really at I must say they're compromised, and when they come to us. Next, please. So did you know what will be the causes of infection? So up to 40%, since we are with the studying about the postmenopausal women, 40% of postmenopausal women experience vaginal dryness. It begins like that during the menopause. Why? Because of the vaginal atrophy. And then there is itching and discomfort. So without the estrogen, why this happens? Because the estrogen level is waning and the pH of the vaginal secretion changes and the normal discharge becomes more and more alkaline. So you are prone to fungal infections. Next, please. So as women gets older, these physical changes which may affect the sexual function. This dryness affects the sexual functions and the relationship difficulties. As it is, you are undergoing hot flushes, you are irritable. On top of it, that you have vaginal dryness, you have partner seeking for sexual gratitude, and then you are having difficulties. So urogenital problems are common symptoms of menopause, and they can involve the vulva, vagina, and of course also the bladder. Next, please. So what can be the causes? Now, these are the lactobacillus which you see. These are the friendly bacteria. So the change in the pH affects the balance. So the microorganism in the natural secretions, they suppresses the normal levels of good bacteria. So the lactobacillus gets suppressed, discharge changes in nature, becomes watery, discolored, and that slightly smelly and sticky feeling gives you really a bad sense and bad taste, and often leads to irritation and cause also the burning of the vulva and the vagina. Next, please. So Candida albicans is the culprit. So Candida albicans, as you can see, lives naturally in the vagina, but it is subdued. Next, please. Whenever the vagina gets moist, vulva gets moist. Next, please. Can you change the slide? Can you change the slide, please? Please, yeah. So Candida albicans, as I said, is a yeast infection, and symptoms can range from mild to moderate, and they include itching, irritation in the vagina and vulva, burning sensation during intercourse, while urinating, and when you see the vulva, it is red and swollen, and soreness is there. Sometimes there is rash is there, and thick white odor-free vaginal discharge, typical curdy white discharge, cottage cheese appearance, and it is a, you can say it is a signs of mild and moderate vulval infection of Candida albicans. Now we talk about complicated. Next, please. Now, complicated, if you have a severe infection such as extensive redness, extensive lot of swelling and itching that may lead to tears, cracks, or sores, then, or you have 4 or more infections in a year, you label it as a complicated yeast infection, or your infection is caused by less typical type of fungus, or you are pregnant, if you are pregnant, not in the menopause, or if you have the, you sometimes diagnose, I have diagnosed so many patients of diabetes with this. They have come to me with candida infection, candidiasis, and then we get the sugar done, and you see that they are not even knowing that they are diabetic. So you have uncontrolled diabetes, or if you have a known case of diabetes, and if you have this curdy discharge, then you can say to the patient that repeat it, and you will see that the sugar has risen and it is uncontrolled. Next, please. So it can be a good indicator. So causes, again, as I have told you, it is a fungus and it is a yeast, and vagina naturally contains balanced mix of yeast, and bacteria and candida both are there. But certain bacteria like lactobacillus, they act to prevent an overgrowth of yeast. So this balance is maintained. But whenever this balance is disrupted, suppose an overgrowth of candida or penetration of the fungus into the deeper vaginal cells, then it causes the signs and symptoms. So excessive use of antibiotics. People are using at random antibiotics, even the dental patients are given or the RMPs are given. This antibiotic use has to be curtailed. So overzealous use of antibiotics, as I said, in pregnancy, I have already told you about diabetes, or an impaired immune system. This we have come to see in HIVs, or we have come to see in corona times. Impaired immune system can play havoc with your system. And taking OCs or hormones, that of course increases the estrogen levels. So next, please. This can lead to candidiasis. So Candida albicans is the most common type of fungus causing yeast infection. So risk factors, antibiotic use, again I've told you, broad spectrum. This is leading to overgrowth, estrogen levels, more common in women with higher estrogen levels, or taking estrogen birth control pills or estrogen hormone therapy. All these women get this. So lowered immunity, or they are, as you're saying, on corticosteroid therapy. There are patients having, you can say, skin allergies, dermatitis, they take lots of steroids, or HIV, they are likely to get yeast infections. So you have to explain to them whenever you are starting with steroid therapy that they might get yeast infections. Next, please. So diagnosis is very easy. First, you have to ask the question, and the detailed history will tell you very simply, is there any history of drug intake? Is there any history of any viral infections when your immunity went down? Or is there any history of hormonal pills you have taken? So all this will tell us about the diagnosis, and diagnosis is easy. First, we do vaginal swab, culture sensitivity. A doctor must send a sample for vaginal fluid for testing, determine the type of fungus causing the yeast infection, identifying the fungus, and more effective treatment, so that specific treatment can be given for recurrent yeast infections. Now, also you must always perform a pelvic examination. History is not enough. Then you have to see the external genitalia. As Madam Chopra has said, even we miss out on herpes simplex. They are very, very small source. So this candida is very, very easy to diagnose. And as you put a speculum, it will be very painful for her. And you can examine the vagina and the cervix also to see is it extending up to the vaginitis or any other thing. Next, please. So treatment, that is the more important part of the chronic fungal infections. It depends again on the severity and frequency. Sometimes only a single dose of fluconazole helps from mild to moderate, or a weekly fluconazole 150 mg we give. Nowadays, we have come up with specific for candidiasis, we are giving itraconazole, oral also we are giving, and we have got a short course of vaginal therapy also we can give. Orally, you can give an antifungal. Also, you give for 7 days this canditrozole or this candid tablets. So many tablets are there which are available as creams, ointments, or suppositories. Then they can be put inside and they can be given over the counter, and others by prescription also they are available. So single dose oral medication, as I said, you can prescribe at one time, or if it is severe, then you can repeat it weekly. And 2 caps itraconazole, we are getting very good results, capsule, and that is very helpful. Apart from that, next please. If the treatment doesn't resolve your symptoms, or if your symptoms are returning, that means it is recurrent types, so severe that your doctor can also recommend long course of vaginal therapy or a medication taken daily up to 2 weeks, followed by once a week for 6 months. And we also combine it with pre and probiotics. So many pre and probiotics like Fembio and all are there, available easily. Or you can have a Yakult, which is there, but you don't apply it locally. You don't try to put water there, or don't try to, because the main cause is moisture. So people try to apply oils, and that patient must be told that you're not supposed to take all that. And azole resistant therapy also you can take. Next, please. Next, please. So alternative medicine, no alternative medicine. I have already told you therapies have to be limited. Vaginal yeast infections. Some complementary alternative therapy may provide some relief, but it has to be in combination with your doctor's care. So next, please. So I must say, so prevention is always better than cure. To reduce the risk of vaginal yeast infections, please wear underwear that has a cotton crotch, and it shouldn't fit too tightly. Everything tight is really exposes so much of humidity trapped. It might also help to avoid tight-fitting pantyhose. Douching, this vaginal washes, I really feel why these vaginal douching and washes are available. Why aren't they banned? Because young girls, they are following all Insta and Google, and then they come to us and they are in bad shape. So which removes some of the normal bacteria also of the vagina, and which of course protects you from infection. So scented feminine products are available, including bubble baths, pads, shampoos, hot tubs, very hot baths, swimming pools I have seen. Unnecessary antibiotic use, such as for colds or any other viral infection that I've already discussed, or they apply even those perfumed talcum powders. They have, Johnson was recently in the news for those talcum powder cancers they had reported. Staying in wet clothes, getting wet, not changing clothes, staying in the office. Nowadays, poor girls are working, so they don't have, that is why we have put so many menstrual hygiene machines in all schools and colleges. So don't stay in wet clothes, such as swimsuits and workout attire. The gym is another place where you get all this moisture and humidity, and for long periods of time. So prevention, girls, prevention is always better. Make your, at 50, 60 menopause, we are having a lot of time on our hands, and we are really gymming and doing everything. So prevention, we must always keep in mind. Next, please. So I think that is all I can say. And thank you so much for giving me this time. And I'm really thankful to this society. And uh, I'm very honored to be chaired by Anjali and Priya and all of you. Bhopal people are very close to Gwalior. Thank you so much.
Shashi Madam, as always, you have covered everything in such a great manner. Though when I looked at the topic, I was what it is going to be. But yes, you have said this very right, and I this message needs to be conveyed to all the youngsters to be very careful from what they are wearing. Andhadhun Western dresses ke chakkar mein our girls are suffering quite a bit. And it is creating a lot of problem, and they will have more issues in longer term when they have marriage and fertility issues come, which probably they are not able to realize at present. Our weather is different, our all other aspects of lifestyle are different.
Thank you. Thank you so much for appreciating. Thank you, ma'am. And it's always a pleasure to be in Bhopal society. Madam, please unmute. I can't hear you. Madam Sushma Chawla, please unmute.
Yes, I enjoyed your talk. Very well delivered. Thank you so much.
Thank you,
Every time you always learn something good. Excellent.
Thank you, ma'am.
हेलो मैम।
Yes.
हेलो मैम, बहुत ही बढ़िया, इतना अच्छा आपने इंफॉर्मेटिव वो दिया है लेक्चर। इट्स रियली गुड। डेली ओपीडी में यही पेशेंट आते हैं, ऐसा लगता है गायनिक ओपीडी से ईचिंग ओपीडी।
Very irritating.
Madam, but I would like you to comment on the weekly fluconazole therapy also, madam. Because that is something new I heard from somewhere. They say that you have to give it weekly for a few months and then monthly and things like that. Oral fluconazole.
So oral 150 mg we are giving, ma'am. And weekly for at least 4 weeks we are giving. For mild to moderate gets okay by that. And also, ma'am, I have seen all these females also need vitamin D. That vitamin D is one big factor for so many immunity issues, and it really helps. So,
one point is, madam, atrophic vaginitis, you over-diagnosed fungal infection. Sometimes allergy to the fungal drug by itself can cause rash. And that has to be treated by steroids. That is one point in perimenopausal ladies who come with itching, and you always think itching is always only because of fungus. And there are pictures on the internet where they are showing it is atrophic dermatitis. It's rash because of antifungal treatment. So that is a double-edged sword that you have to keep in mind when you blindly give antifungal therapy. That is
even
what
madam,
about itraconazole, madam? Anybody uses itraconazole instead of fluconazole?
Yes, itraconazole we are using capsule. 100, 200 mg is available. So 200 mg single dose helps.
No, or do you give it OD for a few days, something like that, for patients who are having chronic infections? Anybody has got that effect, that experience of giving it, like how we said fluconazole weekly for 4 weeks, she said. What about itraconazole? Just because for discussion, I'm saying that.
Yes, sometimes if the patient comes with a repeat infection, I like to give 200 milligrams OD into 5 days.
Okay.
And if it's a vulvitis, I find that the best preparation to combine with itraconazole is local terbinafine, which comes as Ichgard, I think.
Okay, terbinafine has got a steroid component in it. It will take care of the inflammation around the...
Yeah, especially if it's vulvitis, I like to give this.
Madam, in vulvitis, we also give oral steroids also. Visolon works wonders, 5 mg in tapering dose. 3 days.
In my own practice, I find that sometimes this, of course, once in a while you said that you can give terbinafine, but routinely people are using fluconazole, steroids along with antifungal. That may not be a right practice, I feel, because the steroid will mask the effect of the fungus, and even if the fungal infection is not gone, you won't realize it, and then it recurs later on. So I don't know whether we should be routinely giving steroids along with antifungal. What is the practice that everybody is following? Do you prefer plain antifungal first or from the beginning along with steroid antifungal?
If there is
only
a strong
antifungal.
element of itching, I think we would like to add a little steroid mixed cream. And once that itching element has gone off, it's best to use only plain antifungals rather than steroid-based steroid antifungals.
Yes, this is one statement I wanted to come from the seniors, because I think there is a lot of. And what about using the powders, the antifungal powders? Because it is the sweating that causes antifungal.
Yes,
that
Zocon
causes.
dusting powder I am regularly using.
I'm not.
Yes. Okay. So that.
What
that
about probiotics?
Madam?
Probiotics.
Probiotics and prebiotics orally we are giving.
How many days? How many days?
How many days would you like to give?
At least 20 days, 10 to 20 days.
My God. See, we never
So
think
once
of
a
this.
day or twice a day, your dose?
Once
a day or
once. 10 days is enough normally.
It's pretty expensive.
No, otherwise you can use your own probiotics like curd or dokla or fermented foods like that. No, they're all natural. And idli in South India, I think Bhopal, I don't know which. Yeah, so they give natural probiotics.
Madam, Shobna, madam, can you please concisely tell us what exactly is the appropriate treatment, just in few words?
Madam, I thought I gave the topic to another doctor. I thought she will give a better.
I gave, but I got confused now. So I want from the horse's mouth.
No. I can only tell you what we normally do and what I've heard from other people, that you apply antifungal cream for 15 days, which normally people don't do. Once a day preparations are there, twice a day preparations are there. Miconazole and all you have to apply twice or thrice a day. Ketoconazole, it's once a day. Terbinafine is there. What is that? Onabit cream. What is the content of the terbinafine? No?
Yeah.
So that is there. So you have to find out which drug the patient is this thing. Along with that, you can give your probiotics. Antifungal drugs, we are all using only once, and that's it. Pill it, shut it, forget it. That doesn't work sometimes. So you may have to get daily preparations for 1 week and then weekly preparations for 4 weeks. And like Dr. Madhuri said, you give the itraconazole in selected populations. Whom to decide where to give itraconazole and where to give fluconazole, we cannot say. Severe itching cases, she said you have to start, give a combination of steroid first, but then if you continuously give steroids, it's going to be difficult. Therefore, you give a plain antifungal treatment after the steroid itching is gone. And please continue for 15 days. One thing is change of underclothes, because the underclothes, even if you wash it in boiling water, it's not going to work. Therefore, you have to just throw out all your underclothes and get a fresh new pair of underclothes. Totally, so that you do not get the chronic fungal infections again. Or maybe using too many underclothes, that is also one, change them regularly so that you don't use the same 5 or 6 ones every day. So all these things might probably help. Use of fungal or any other preparations, and then not keeping a moist vulva by using underclothes, which you just pass urine or something and then you don't wipe. Either you wash or you don't wash, but you don't wipe the area, and then that area remains moist.
Yeah.
So this patient, we have to tell them to use a cloth or a tissue to wipe the area. That is very important in chronic. Yes, Deepa.
Dr. Shobna, I am advised for panty liner also.
The panty who's that sort, no? Yeah. Liners are there. For stress incontinence, SUI, cases of SUI.
No, not big pads, only small pads, panty liner.
So that will absorb the moisture.
Yeah.
That I have not heard of that. Maybe that's a good tip.
No, I am regularly using.
Very good, and you are finding your chronic fungal infection patients are getting better with the use of.
Yeah. Very good.
This is another tip that we can try to use in our patients.
Yes.
But that liner will have to be changed frequently.
And the patient is not responding.
The liner has to be thrown out once it is used. Not like panties. Yeah, instead of buying new set of panties, you use panty liners. So you can save money. That's what Dr. Sarla is saying. Why do you want to make them buy new dresses every time? You just throw out the panty liners and that's done.
And madam, people have a habit of washing after going to the urination. So
yeah,
that
but then they don't wipe.
but should be dried at the same
It should
time.
be dry. Keep the vagina dry.
So what is the role of probiotics? What is the role of probiotics in fungal infection?
It's good.
Probiotics for all
Good.
infections, it's good, and suppose we must encourage the use of probiotics in our
But why,
patients.
ma'am? There's no role of probiotics in
Maintain the
fungal
pH.
unless until it is super added by bacterial infection or something. You're giving
Madam,
antibiotics.
probiotics improve the antioxidant levels of the body, whichever way you say it.
Yes.
And the antioxidant levels are increased, then all your TNF, alpha, everything increases, whatever infection is there in your body. Your immune system is definitely acted. It's not just antibacterial, probiotics. The drugs, there is prebiotic, probiotic, all these things definitely are important in any infection. They improve your immune profile. I had given a whole lecture on this in Baroda. I'll have to open my PPT to answer your question now.
Okay.
I cannot offhand, I cannot tell you. Give me
You
time,
can
I'll open the PPT and I will read it out to you.
Madam, share it on the group. Share it on the group. Would love to.
No, but some other time we'll have a talk on that.
Okay,
Yes,
ma'am.
but I'll, believe me, I will send it to Deepa. Deepa is the one who is asking me. So I'll send
Even panty liners are not advised because continuously it is the infection will be there only. It's better to use cotton panties, wash them 2 or 3 times, and not to use panty liners. Otherwise, reinfection keeps on happening. Those panty liners
No,
are
but
another
your
source of
panty liners are
infection.
thrown away, no? Then why should you get
Yes, yes.
No, but as long as it is, supposing you are applying it for 4 hours also, then also the same, this thing is there.
No, it's better
There
than
is a lot
using
of
the panties
moisture
for
part
12 hours. Now use the panty liner for 4 hours. Anyway, Sarla Jain has used it in her patients and she has found it. So
They're getting very good
let's take it
response.
from her instead of books. She says she has tried it in her patients, then maybe it's useful. We don't know. It's loud thinking from Deepa Kapoor from Lucknow. But Sarla Jain says she's used it in her patients and she's found it useful, then we have to listen to that.
Yes.
But yes, Madam Sushma is saying something, but you have to unmute yourself, Madam.
And partners, of course, should be treated always. Partners should be treated. That is
Partner pad, yes.
The panty liner is a
And if the
very.
patient
Madam Sushma, what do you say?
and if the patient is not responding, if the patient is not responding within for a week, we should change the steroid.
No, you can
And
change the
antifungals too.
antifungal cream or you can add steroid.
The panty liner is a very useful thing for your personal use also, rather than
Otherwise-
changing it otherwise also. While traveling, even otherwise, if you change the panty liner after 4 hours, anytime you go to
So
toilet.
Jalandhar
I
and
think
Bhopal are hand in
Yes,
hand and
yes,
Lucknow is little
yes.
reluctant.
No,
Because, Madam, humidity matters. Humidity matters. Whereas there is more humidity.
But Trishur is neutral, by the way.
No, for prevention of recurrence, can we go for this probiotics? That will be useful, no? Prevention of recurrence.
Yeah, that's what. There is a, why Deepa is asking if there is no bacteria, why use probiotics? I said I'll open my PPT and tell you. So, okay, then I think we are just repeating whatever we said again and again.
Ma'am, there's a condition, excuse me, ma'am.
Yes, madam.
Ma'am, there's a condition known as cytolytic vaginosis.
Okay.
When the patient is not responding to antifungals, we have to think of that. It is actually a lactobacillus overgrowth syndrome. And and probiotics are very harmful in that condition. So if we keep
How
on
do we
giving
know if
antifungals and
that
probiotics,
condition is there?
cytolytic vaginosis or Doderlein syndrome.
Madam, how do you find out if that patient has got that syndrome?
The treatment is very simple. The treatment is only bicarbonate tablets.
That is treatment. What is the diagnosis?
Diagnose how to diagnose.
Antibiotics.
On a cytology, it is reported as on the LBC reports, it is reported as cytolysis. We recently came to know about this condition in the registry group. There was a discussion. And
okay, that's okay, but none of us have seen it. So you just send it for a routine cytology, and if there is no cytolysis, you don't have to get worried about probiotics.
And if the patient is not responding to antifungals, then we have to think about cytolytic vaginosis.
But then only unless and until proved, why you cannot start worrying about it. Unless and until proved on cytology, how can you say it is cytolysis?
Ma'am, it is a condition in which
There
we can
is a
think
condition,
about
but whether
if the
your
patient is
has
not
got that
responding.
condition. If the patient is not responding, you need a diagnosis.
We have
Then
had
it's
a
not
very
a diagnosis of exclusion. It is a diagnosis of cytology, right?
Excellent cytology.
Cytology, yes.
Ma'am, it can be diagnosed on a vaginal smear.
Yeah, so you do that and diagnose it, then you avoid your probiotics.
Yeah, and
You
there
can
is
do
there
it.
is an
It's
excess
not
of
a diagnosis of
lactobacilli.
exclusion.
Yeah, on a vaginal smear, the diagnosis can be on a
There has
vaginal
been-
smear, an excess of lactobacilli are seen.
Okay, so we are anybody who is not responding, before you put them only on probiotics and panty liners and everything, listen to the IMS registry group and do a cytology. That's a good point, no problem. But if you don't find cytolysis or you don't find orderlinks or bacilli or whatever, then you don't have to worry. You can give your probiotics, right?
It was a very. I like to thank Dr. Shashi Bala. It has been a very enlightening lecture, along with lot of questions and lot of doubt clearings, not only about the medical part, but also the social part and about panty liners. There were so many questions and things like that. So in a way, it was helpful to all of us. And we'd like to thank our President, Sir, Madam, and Dr. Shashibala for this graceful
Thank you,
lecture.
ma'am.
Thank you.
Thank you so much for giving me this opportunity to be with you all.
Thank you, Sarah.
Thanks all for this academic feast. Ma'am, would you like to say something? Dr. Meenakshi, ma'am? Do you want to say something? Okay, thanks all for
I
this
just want
academic
to
feast.
comment on the end-to-wash lotions which are available these days. Any comment on that?
Yeah, it's
Into-wash,
a good
V-wash,
thing, but I don't think it's routinely necessary.
No.
Because
these
washes are
patients
not
we usually tend
recommended.
to use.
In infections not getting treated, I would recommend not routine use of vaginal douches, just like you use your soap for vulva daily, you douche everybody and it's advertised on the TV. I do not think that much is necessary. That's my point of view.
Very true.
Somebody
Okay,
was
thanks
saying, patient is not even allowing you to touch the vulva. How will you give injections? That is one thing to answer. You have to start with drug therapy first. Then you use gel first. Then you think of injections. I had clearly said in my talk, it's not injections for everybody. You try your venlafaxine and you try your gabapentin, you try your paroxetine. Then you try your gel, xylocaine gel overnight for 8 hours. And then if that doesn't work, you buy the patient's confidence with drugs and gel and everything. And for the last portion, then only you can go and give your injections, or maybe surgery is also there. There you can anesthetize the patient. That's all I can say. Okay, now over to you, organizers.
Absolutely, ma'am. So thanks all for this academic feast. It's a very thought-provoking talk by Dr. Pam. Ma'am, we love you now more than previously. And you have been so humble by asking herself so many questions and, provoking more questioning from all the delegates and faculties. This is the information you imparted on this chronic fungal infection. This was indeed very important and informative. Now, taking this session forward, I would like to invite my friend Dr. Monica Singh to share her immense knowledge and skills. If one takes a closer look at the alchemy of an achiever, two distinct virtues pop up. Beside perseverance and hard work, these are pioneering spirit and willingness. Our next speaker is a perfect example of this. I would like to invite Dr. Monica Singh. She is MD, DNB, FMAS, FICOG, consultant reproductive medicine, gynec endoscopy, and fetal medicine from Bhopal, Test Tube Baby Center, Bhopal. She is associate professor, Obs and Gynae, Allen Medical College, Vice President, Bhopal Obs and Gynae Society, Treasurer, MP Chapter, ISAR, Vice President, Bhopal Menopause Society, and Founder, Secretary, MP Chapter,
we'll move on.
IFS. Monica, you have so many accolades in your CV that at least allow me to say a few things. She has been awarded by Lions Club Bhopal, Swami Vivekanand Library Bhopal, and People's Group Bhopal on several occasions. She has a special interest in PCOS, poor responders in ART. advanced ultrasonography and has presented more than 100 original studies in ASHRAE, ASRM, Aspire. She is an active life member of ISAR IFS. And now I welcome Dr. Monica Singh to kindly continue the flow of knowledge with the second session.
Thank you so much.
Over to Monica.
Thank you so much, Dr. Aradhana. And taking the session forward, as we know, we are a little short of time here. Hope the organizers give us some extra time here. Moving on from the benign conditions of the vulva, which are nonetheless very distressing, that is vulvodynia and the chronic fungal infections, which made up for some interesting discussion in the whole previous 1 hour and a half. Let us move on to the more sinister aspect of the vulval diseases, and that is the precancerous and cancerous lesions of the vulva. And for this, we have one of the most enlightened speakers of Bhopal, who is a master on this subject, and we are all very proud of her. I invite my moderator, Dr. Madhuri Chandra, to conduct a panel, a brilliant panel on the precancerous and cancerous lesions of the vulva. Can we have a CV, or I can read it from my phone also? Dr. Madhuri Chandra is a well-known figure in Bhopal Obstetrics and Gynecology Society. She is MD, DNB, FECOG, CMCL, FAMER Fellow, and former professor and unit head of Obstetrics and Gynecology, GMC Bhopal. She has been ICOG Governing Council member 2017 to 20. She has been the president of Bhopal Menopause.
Monica, can I interrupt you? We are a little short of time, so why don't you introduce the others also? I think 2 lines on everybody will be more than enough.
Yes.
Thank you so much.
Yes. Thank you, Dr. Madhuri. And I invite our panelists. Our first panelist is Dr. Amita Maheshwari, Dr. Bhagyalakshmi. Dr. Bhagyalakshmi Nayak deserves a special mention here because she has contributed a lot of academic and logistic support to this discussion. And my president, Dr. Shashi Srivastava, made a special mention of her, that Monica, you have to emphasize how much she has helped us in this panel. She is a professor in Department of Gynecologic Oncology in Cuttack, co-chair Oncology Committee CEPHO, Governing Council member ICOG, chairperson Oncology Committee FOXY 18 to 20, joint secretary AGOI, and a peer reviewer of reputed journals.
Madam, you will have to do one-liners for the panelists because we will not finish otherwise.
Thank you. So I invite our next panelist, Dr. Amita Maheshwari, is again a very accomplished professor and head division of gynecologic oncology, Tata Memorial Hospital, and Mumbai president-elect. Madam, I welcome you. We have Atul Somaiya. He is senior consultant, surgical oncology and head oncology services, Bansal Hospital, Bhopal, one of the biggest corporate hospitals of Bhopal. He's done brilliant work and published several chapters in books, authored several chapters, and presented numerous papers. I present before you Dr. Meeta Agarwal. She's a pass out from LLRM Medical College, Meerut, gold medalist, a very accomplished private practitioner. My president of Bhopal FOXY when I was secretary 2015-16, past secretary IMS.
Madam,
she has been awarded.
Madam, please shift over.
Okay, next is my panelist is Dr. Shraddha Agarwal. She's again a very, very senior gynecologist of Bhopal, working in the district hospital Bhopal, eminent LTT surgeon, and
next,
has
madam,
been
please next.
Yes. Dr. Gaurav Gupta is a radiation oncologist. He is trained at Delhi State Cancer Institute, Delhi, and working in Bansal Hospital, Bhopal. Welcome all. And over to Dr. Madhuri Chandra ma'am for conducting this panel.
Okay, thank you, Monica. I'll start screen sharing. Okay. Thank you for introducing my panelists. I've got a very rich panel. 3 eminent gynecologists from Bhopal. Then we've got 2 stalwarts of gynec oncology, Dr. Amita and Dr. Bhagyalakshmi. We've got a surgical oncologist and we've got a radiation oncologist.
And ma'am,
so let us start off.
Dr. Shashi Srivastava is also in the panel.
Yes, you forgot her, but she's mentioned in the 3.
I'm extremely sorry.
Okay. So when we talk of the vulva, we are talking of the mons pubis and the vulva, that is the anterior triangle. The vulva is considered consisting of hair-bearing labia majora, the labia minora, clitoris, and two glands, that the Sheen and the Bartholin's glands, plus the opening of the urethra and a little part of the vagina. If you think about vulval cancers, they are not very, very common. In my 30 plus years at GMC, I think I must have dealt with only about 5-6 cases. There's no specific screening for vulval cancer, and the most effective strategy to reduce the vulval cancers is to do opportunate treatment of predisposing and pre-neoplastic lesions, which we'll take first. The most women would present with vulval pruritus or pain, or have a lump or an ulcer, and vulval biopsy should be done to exclude any VIN or vulval cancer. The most common type of which is a squamous cell cancer. Now, I would put my first question to Dr. Meeta. We are saying we must look out for the predisposing factors for cancer vulva. So can you enumerate what are the predisposing factors, Dr. Meeta?
Yes, Dr. Madhuri. I think whatever, because as you have said, we are seeing very less cases. Hardly we have seen any case of cancer vulva, but the causes which are important for lower genital tract, like cervical cancer, like history of smoking, like prior history of cervical cancer or cervical pathology, like CIN, where if it is present, or patient is immunosuppressed for any reason, if she is on steroids or was taking treatment for some other ailment. So, and history of HPV is very important, because in young patients it has been seen that it is the vulval cancer has been associated with HPV. So all these things we have to take in account, and then look out for all these infections and rule out once, and always examine with vulva whenever we are examining our patient, so that we can find if some ailment is there or not.
Okay, so straight away we'll start with the first case that we have. She's a 60-year-old woman. She presented with this white lesion, which was surrounding the perineum and the perianal region in a figure of 8 manner. There was small introital contracture and a thinning of that skin in that area. She was also having intense pruritus, dysuria, and dyspareunia. Dr. Shashi, what do you think this diagnosis would possibly be?
This might
a spot diagnosis.
Yeah, this might be a case of lichen sclerosis, because the age is one of the factor, because it occurs most commonly in a postmenopausal age or prepubertal girls. Involvement of perianal involvement is frequently seen, just like here. Typically white atrophic papules may coalesce into the porcelain white plaque. They distort the normal anatomy of the vulva. And as a result, labia minora regress, clitoral concealment, urethral obstruction, and introitus stenosis may develop. Skin generally thin and crinkled. Over time, perineum anus involvement leads to formation of figure of 8, as you mentioned here, or hourglass shape. So sometimes asymptomatic, generally anogenital symptoms that worsen at night. Pruritus leads to excoriation of vulva, skin thickening, and it leads to vulval skin fragility. Structure changes, causes burning and dyspareunia. Causes unknown. Case skin biopsy is the confirmatory and also the rule out the pre-invasive and malignant lesion. Just as shown here, in the left side, there is a lichen sclerosis atrophic, where the squamous cells, and right side, squamous cells hyperplasia with hyperkeratinosis. Younger women are more involved in this type, and lichen sclerosis atrophic, generally perimenopause age group. In a squamous cell hyperplasia, they are focal, never extend to anus, associated with dysplasia. VIS and invasive cancers may be occur in a 10 to 30%. Symptoms less or may intense pruritus that may lead to secondary infection and dyspareunia.
Thank you, Dr. Shashi. You've already said a biopsy should be done, but my next question is to Dr. Shraddha Agrawal. What would aid in the diagnosis and how will you manage this patient?
For the diagnosis, we need biopsy, and we use case punch biopsy, which is mostly used by the dermatologist. And since it is associated with many infections like trichomonas and candidiasis, so vaginal swab will be helpful. And vulvar dystrophies are also associated with many autoimmune diseases, which is so we test for acromegaly. And diabetes is one of the most known factors for vulval itching. So glucose tolerance should be done. Many deficiency diseases, vitamins like folate and B12 are also responsible. So test for folate and B12 also.
And what about the treatment? What treatment would you like to give?
First of all, we advise the patient, as we have discussed, to change to cotton garments, and they should be loose. Normal emollients can be used, but if we find some deficiency diseases, iron and folic acid to be given. If she is diabetic, diabetes should be treated first before giving any other treatment. And fungicides, as we have discussed, can be used. Another is Kenalog, that is triamcinolone acetate injection can be given. Clobetasol propionate is a local steroid. If infection is also associated, we should add antibiotics, which gives 70% cure. Testosterone is also very helpful, which increases vascularity, and that should be tried. If in refractory cases, we can give circular incision around labia, that is Mering's procedure, which cuts off ilioinguinal branches, and that will decrease the sensitivity. Absolute alcohol can be injected. Vulvectomy in very resistant cases, and it should be avoided as it has got a psychological trauma. Topical calcineurin inhibitors.
टेबल है जिस पे हम पढ़ाई कर रहे हैं ना, उस पे हम पैर क्यों रखेंगे?
By inhibiting synthesis of pro-inflammatory cytokines, and they are nowadays using for atopic dermatitis, and it is alternative to steroids. Secondly, we can also use retinoids. They also increase vascularity, and stem cell can also be tried.
Thank you, Dr. Shraddha. So the summing up of this is that lichen sclerosis may be just a dystrophy, but epithelial disorders, they require continuous supervision for an indefinite period because of this risk of going into VIN or vulval cancer. With that, we take on to a second case. She's a 45-year-old woman, para 3, all live, and she presented with multiple small growths on her vulva and complaints of white discharge per vagina. Her last pap smear was a year back, and it was NILM, that is no intraepithelial or malignant cells seen. Dr. Shashi, what would be the diagnosis, probable diagnosis, tentative diagnosis?
Probably, this is a case of viral warts or papillary varices lesion of the HPV caused by 6 and 11. These are multiple, and generally the age group is sexually active persons. They transmitted by sexually and highly contagious. On examination, it may be warm, moisture, vaginal discharge may be there. And during pregnancy, these warts may increase in size, finely branched and narrow stalks. Mostly posterior faucet, lateral areas, or maybe sometimes inside introitus. So most probably viral warts.
Okay, Shraddha, what could be the management then? What management would you like to do?
Still, we are using podophyllin, that is podovort, and which is a resin. It can be used topically, and the best way to use it with the help of earbud, so that it can be localized. It is cytotoxic, and normal skin should be avoided. It is to be applied at the base. And another thing, important precaution is not to be used during pregnancy. Trichloroacetic acid can be tried for 6 weeks in weekly interval, and it can be used during pregnancy also. Cautery and diathermy cryotherapy can be tried, but in large warts. These are effective only when the diameter is less than 1 to 2 centimeter. If it is more than that, large wart should be snipped off and cautery should be, and the base should be cauterized. Recurrence rate is 30%. Now we have HPV vaccine, but it is too early to say because we are using it for last 15 years. Now we will see the effect on warts also. If the incidence increases, that means this is effective. Otherwise, we have to see.
Thank you, Dr. Shraddha.
Yeah.
Madhuri, can I add? We move on to vulval intraepithelial neoplasias. There is an increasing incidence. More likely, we are getting patients with less than 40 years of age. Is it because of the increased incidence of HPV infections? Is it because of smoking, obesity, diabetes? The two intraepithelial neoplasias that we are going to talk about are the squamous vein and the Paget's disease. The ISSVD classification was also referred to by Dr. Shobna in her lecture. We've seen a transaction in the classification, and now we've got two. What was first known as VIN1 is now low-grade vulval lesions, and this includes flat condylomas or low-risk HPV infections. Then VIN2 and 3 is now called high-grade squamous intraepithelial vulval lesions. The usual VIN associated with high-risk HPV infection and can progress to invasive cancer, and the differentiated VIN, which develops in chronic skin lesions like lichen sclerosis. So we have our third case. She's a patient, 56 years of age, menopause since the last 10 years, complaining of pruritus and soreness of the vulva. Dr. Bhaglakshmi, what could be the tentative diagnosis and the next step?
Hello, can you hear me?
Yes, yes.
Is there a lot of echo?
Yes.
Sorry, I think there's some issue with my computer.
Your voice is echoing, but we can hear you.
You have logged in from two devices, madam, probably. Please log out from one device.
No, I'm only in one device. Okay, so I think when you look at the lesion, it has many kinds of colors on the skin. So there is some kind of discoloration. There is also pruritus. So I think it needs some kind of workup. So the first we would do some kind of colluding blue list or a proper vulvoscopy biopsy. Sponge biopsy is the main instrument which will be used. So, and then identify the exact lesion when we need to biopsy, and after the biopsy, then we proceed with the treatment, because some kind of invasive disease also along with this lesion. So we have to be 200% confirm what the lesion is. So this is called a in which aqueous solution of toluidine blue is added. The skin application takes 2 minutes. Vulvar epithelium is discolored with acetic acid, and then the stent will be entirely washed from the normal skin. Epithelium does not contain nuclei, and any condition that results in the presence is due to the nucleic acids that are present in the hyperchromatic. So I think after the biopsy, once we have a biopsy report, yes, I think vulvoscopy is also a very important thing. So what do I do for my echo? Can you give me 5 minutes?
Maybe try putting off your video, madam.
So is it better now?
Yeah, it's definitely better.
Okay,
it's not echoing.
Okay. So I think yeah, once I start speaking, it goes. So I think this 3-ring vulvoscopy is a very important thing. So actually, it is a very proper and stepwise colposcopy, which is little special, so that we don't miss out anything.
So it's a deliberate colposcopy which is done on the 3 parts of the vulva, as the inner ring, middle ring, and the outer ring, so that we do it very thoroughly and properly, and we don't miss out anything. So that's the main basis of vulvoscopy, and I think vulvoscopy is the gold standard. It may be a little difficult in dark skin, but I think still with a good light source, you can still be able to identify lesions. So I think doing a proper vulvoscopy and a toluidine blue test will really help you identify the area from where you will need to take the biopsy.
Thank you, Dr. Bhaglakshmi. So a vulvoscopy was done and a dense aceto-white area was identified. Dr. Amita, what would be your next step?
Hi, very good evening. So thank you very much for the invitation. It's pleasure to be here. Just couple of things before I go to this where to take a biopsy, if I can make points. One is, see, vulvoscopy, there is no special scope. It's the colposcopy which we use for examination of vulva and call it vulvoscopy. That's my understanding. And in case you do not have that, so that should not be an excuse not to do a good vulvar examination. A bright light and even a magnifying glass is good enough. So if you do not have a colposcope or anything, so just examining vulva under bright light, under low magnification. We really don't require very high magnification for vulva. And in case toluidine blue is not there, then little controversial, but acetic acid 5%, applying it for a little longer, 4 to 5 minutes, can also delineate dysplastic lesions. So these are a couple of points I wanted to make. And also on the previous, when we were discussing genital warts, we have a good experience using imiquimod. Nowadays, we do not use podophyllin, we use imiquimod for genital warts, and we have got very good results. Essentially, it's an immune modifier drug, and it works very beautifully in genital warts. Now, coming to this particular case, when there is a aceto-white lesion which is grossly looking abnormal, the next step is to take a biopsy. Now, again, a point I want to make, in case we don't have key sponge biopsy, which many of us may not have, knife biopsy or scalpel biopsy, or even like not here, but your regular cervical punch biopsy forceps when there is a frank growth is also absolutely all right. But this is the ideal instrument to have key sponge biopsy. So you put it, you have to give local infiltration, local anesthetic before doing any biopsy. And once you are sure that local has worked, just put this instrument, key sponge biopsy, perpendicular to the skin. It's essentially, you have to put it down and just take a kind of core of the tissue. And if in doubt, one can take multiple biopsies. There is no problem in taking multiple biopsy. A small bleed is quite common after biopsy. So either silver nitrate or Monsil solution, whatever is available, can be used. But if it's a larger bleed, if it's not controlled by pressure and other measures, then stitches are also fine. So these are some of the points I wanted to make. And also, once the biopsy is taken, orient it and send to the pathologist with proper orientation.
Thank you, Dr. Amita. Dr. Bhaglakshmi, give us some more indication which vulval lesions should we always biopsy?
Yeah, I think if it doesn't fit into your clinical scenario, or there's a progressive lesion, or maybe it's not responding to your standard treatment, or maybe pigmented lesions. So I think whenever you are in a doubt, I think it's always better to biopsy the lesions than go on and on with the same clobetasol and all those regular treatment. So I think we should not shy away from taking a biopsy. I think it's a simple procedure, and I think it's not a very difficult thing. And as Dr. Amita has already mentioned, you can always use your cervical punch biopsies if you have, but then I think they have to be a little sharp, because otherwise the tissue gets crushed. So that's where we miss out on the diagnosis.
Thank you, Dr. Bhaglakshmi. Now I'm going to ask a very stupid question. It may seem stupid, but we are all gynecologists sitting over here. And we know that for cervical cancers, you should do HPV test. And we know how to take an HPV test along with a liquid-based cytology very well. If we are thinking that HPV also causes vulval cancers, how do you do a HPV test for on vulval lesions?
Yeah, so I think we have a broom-like structure which can be used for taking the cervical smear, and I think that's the same broom which we can use on the vulval skin and take the scrapings and put it into the liquid medium. So I think it's not different at all. We can use the same soft bristle like broom like structure which we are using for the cervical cancer. We are using the same thing.
Thank you, Dr.
A point here, Bhagya very rightly said that if required, we can use the same thing. But two things. One, currently HPV vaccines are not approved for prevention of vulvar cancer. You know, that's a by positive effect additional. But not for prevention of vulvar cancer. And second, like cervical cancer screening, there is nothing like vulvar cancer screening. If you are seeing a lesion, you biopsy it, but not to scrape the entire vulva. And third point is, unlike cervical cancer, where we know more than 95% of cervical cancers are because of high risk HPV, a substantial proportion of vulvar cancers are, especially in our, still in our country, are not HPV related. You know, the one which are lichen sclerosis associated occur in older women, and unifocal, these are not HPV related cancer. So it's not really required. And how to get a diagnosis whether it is HPV associated or not is actually, once you take a biopsy, P16, which is immunohistochemical stain, should be done on the biopsy tissue. So HPV associated cancers anywhere in the body will be P16 positive, while in the background, if tumor is on the background of lichen sclerosis or other skin disorders like lichen chronicus or lichen planus, we will not see HPV. I mean P16 IHC.
Thank you, Dr. Amita. Thank you for clarification. So what are the management options for VIN? And how was this particular patient managed? Dr. Bhaglakshmi?
Yeah. So I think we have many options in our hand, and the most important deciding factor is about the centricity of the lesions, if they are multicentric, and about the age of the patient. I think these are the two important things which we really take into account before planning any management. So if they are multicentric and really are spread out over a wide area, and we really would like to start them off with imiquimod treatment. I think imiquimod has come up in a big way, and we need a little bit of patience while using imiquimod, but I think it really works in young women. But if it is a unifocal lesion and in an elderly woman, as this case was, I think a wide local excision with a 0.5 centimeter of margin is quite good enough. And really, we don't need to take too much of depth in these lesions. But I think we have to be 200% sure that there is no invasive cancer in the lesion. So that's the crux of it. And then after, again, the wide local excision, we are sending it again for biopsy to look at the margins, to look at the base. But in spite of the margins being negative or being positive, still we keep them on follow-up and have a close watch, because many times they would also recur. So that's another issue. And in these cases also, because the new WHO guidelines are again the vulval cancers have to be you have to keep a documentation of whether they are HPV positive or negative. So I think in all vulval cancer cases we are doing the HPV testing, because is an addition, but we do the HPV testing for all vulval cancers.
सर्वर नहीं चल रहा था तो आज
Thank you, Dr. Bhaglakshmi.
A
few words on the prevention of VIN or cancer cervix. Dr. Anjali, can you just off your audio?
39 तक जी सर 17 जी
Anjali?
सर आज के तो साथ ही
Anjali,
हैं.
can you just off your or unmute your mute yourself?
I'm calling her, ma'am.
Okay, so we go on to prevention of this, and I call on first Dr. Meeta to tell us something about prevention of vulval intraepithelial lesions and cancer vulva. Dr. Meeta?
Yes, as Dr. Amita has said, it has not been proved that HPV vaccination is important for prevention of vulval cancer. Still, primary prevention is by HPV vaccination. That way, we can prevent other cancers also, and simultaneously we can examine the patient. And secondary prevention is always examination, diagnosis, and management. So one has to diagnose whenever we are seeing a patient, whenever we are evaluating a patient for other lesions like pap smear or HPV test, or patient has to self-examination is also very important, because she may come up with history of thickening, pruritus, and some lesion is there. And if there is any change in color or chronic vulval pruritus, then we have to do early evaluation of these patients. We have to take a biopsy, which is very important, examine, and then rule out if there is any vulval dystrophy. And tertiary prevention is treatment of all the opportunity lesions which we may think of even if it is cancerous or precancerous. We have to treat these patients and diagnose in time and follow up to find which type of cancer is there. As we have seen that there are two pathways which can lead to vulval cancer: keratinizing, which is predisposed by lichen sclerosis, and other is faulty or basaloid carcinoma, which is mostly associated with HPV. So we have to diagnose whenever we see a patient, and simultaneously, whenever we are seeing these patients, we have to examine vagina, anus, urethra, look for lymphadenopathies if we find any lesion which may be implicated as it is a precancerous lesion.
Thank you, Dr. Meeta. So we go on to our case 4, who's a 70-year-old woman. She's got chronic pruritus for the past 6 months, along with burning and a constant moist feeling. On examination, you have eczematoid erythematous white plaque. It looks like an icing on the cake appearance. Dr. Meeta, what could be the probable diagnosis and what investigations would you like to do?
The classical elderly lady with history of chronic severe itching with eczematous, although erythema in Indian women is not very well seen because of our dark skin. But this sort of appearance, one differential would be Paget's disease. So I think here that was, and Paget's essentially it's in vulva. Primary Paget's generally it's an intraepithelial neoplasia. Invasive Paget's primary vulva is very rare. So this is how, like, it's a histologic pathological diagnosis where you see Paget's cells which are polymorphic hyperchromatic cytoplasm, pale vacuolated, contains, this is for pathologists to tell us. So as I said, primary invasive Paget's of vulva is extremely rare, but whenever we see Paget's disease of vulva, we have to rule out other common sites like breast. We do mammography. You also have to look for urinary bladder and urethra, so a cystoscopy and urine cytology, and also anogenital, anal, essentially a colonoscopy. So these are the basic things we do whenever Paget's disease is there.
Thank you, ma'am. And how would you manage this patient, Dr. Bhagyalakshmi?
Yeah, so I think Paget's disease is not a very common thing, and the most important thing about this is that how much we see, but the margins has to be a little more than the squamous cell carcinomas, because it is usually the margins are very indolent and very difficult to approach. So the margins have to be taken more, and the frozen section of the margins maybe taken help of too, so that we get a clear margin, because we do not have, it's not a very radiosensitive disease. And number 2 is that that's a special surgery called a Mohs surgery, in which we go on doing the surgery and sending it for frozen section and stop where the margins become negative. So I think it's a little tricky surgery, but we need to take a good depth and a good margin, because many times they would have some kind of insidious diseases which are spread beyond what we could see normally. So the margins are a little more than normal vulval cancers, what we see.
So here's the picture of a wide local excision with flap repair. And the HPR confirmed that it was Paget's disease with no evidence of invasion, and the margins were free. We go on to our case 5. This is very interesting because she's just 28 years old. She delivered about 15 days back. The child is not alive. There's a large growth on the vulva, more than 8 centimeters on the right labia majora. It extends onto the urethra, anus, and the clitoris. and her HPR came out to be squamous cell carcinoma. What other investigations would you like done, Dr. Shraddha? Dr. Shraddha, are you still there?
Yes, yes. Around 20% of vulval cancers, they are associated with cervical cancer. So first of all, since growth is there, we will take the vulval biopsy. We all have discussed the instruments. And since 20% associated with cervical cancer, so we will do colposcopy. And as Madam has told that we should always see for the other genital cancers also, CT abdomen and pelvis should be done to see to do the staging and to do the spread. Surgical staging is must, and final diagnosis by doing histopathological examination of vulval growth and the lymph nodes.
Dr. Amita, what would be your management plan for this patient? She's got a large growth, 8 centimeters, young.
Yeah, so although we don't have her clinical photograph, but presuming that it is involving urethra and anal canal, we would give neoadjuvant chemotherapy and reassess for surgery. That is one option. Alternative could be neoadjuvant chemoradiation, a combination of radiation along with chemotherapy. Whichever one way we want to, do it, it's fine. And also young patients, so this may be, HPV associated most probably, and would also do HIV testing definitely on her, because at 25 getting such aggressive tumor.
Dr. Amita, she was given neoadjuvant chemotherapy. The reactions and toxicity were quite significant. Response was poor. There was a large nodal disease also, though the PET CT showed no distant metastasis. And this is what she looked like after the neoadjuvant chemotherapy. And the next photograph is the appearance after the excision of the growth. Now, what about upfront CT-RT, Dr. Gaurav, in this patient?
Ma'am, in such cases, in locally advanced disease with involvement of urethra and anus, what I would recommend is a multimodality treatment. Ideally, if we want to go for radical chemoradiotherapy, we can go for radical radiation to a dose of 60 to 70 gray over 6 to 7 weeks, along with concurrent chemotherapy. We usually cisplatin based on a weekly basis.
Thank you, Dr. Gaur. Dr. Amita already mentioned the two choices, that is either neoadjuvant chemotherapy or a upfront CT-RT. Now, we've got the options for both. So what could be the possible complications of giving chemoradiation in this patient?
Ma'am, the most common complication is local moist desquamation of skin of perineum and inguinal ports, followed by diarrhea, cystitis, increased frequency of micturition, dryness of vagina, and fracture of femur. But with advanced radiotherapy techniques, these complications have gone down except for moist desquamation. Rarely we do see cystitis and proctitis. And fracture of head femur have gone down significantly.
The HPR was invasive squamous cell carcinoma, well differentiated, margin near urethra were positive, base was negative, and bilateral nodes were metastatic. Dr. Gaurav, now what would you do?
Ma'am, since base is positive and she is having metastatic lymph nodes, so I would ask for an adjuvant chemoradiotherapy.
Okay.
Yeah, adjuvant radiotherapy to a dose of 55 to 60 gray along with cisplatin-based weekly chemotherapy. And yeah, investigation, we have already done PET CT in this particular case, so no gain of going for CT scan or CT scan abdo-pelvis. Else, if we have not done, then we should do.
Okay. Now my question is to Dr. Atul. Dr. Gaurav has also already said what he's going to do with the pelvic nodes. What about you? Would you like to go in to the pelvic nodes and do a surgical assessment of the pelvic nodes?
Good evening, everyone. Basically, if we have to assess clinically and radiologically whether nodes are, what are the size of nodes and they are resectable or not. So these are the two important points we have to take into consideration. And in this patient, because already planned for the neoadjuvant chemotherapy, So I would not like to plan a initial inguinal lymph node dissection for these patients because neoadjuvant chemotherapy is already planned. If we would have gone for the chemo radiation, probably if the nodes are large, because any lymph node which is around 3 centimeters or more, unlikely to be responding to completely to radiotherapy. So in those cases, probably it is better to have a first surgery, stage the disease, and then plan for the chemo radiation.
Thank you. I think we've already covered this, and the patient was given CCRT, and this are the photographs after that. The concerns, of course, was the young age, delay in diagnosis, and probably it was a combination of both patient and provider. Dr. Bhaglakshmi, what follow-up did you advise on this patient?
So actually, she had extensive inguinal disease, and the inguinal area was also infected and sloughed out for quite some days. But then gradually she responded, and then of course she had a NAD status for quite some time. So we called her back every 2 to 4 months for the first 2 years, then every 3 to 6 months for the next 3 years. And each time we had a physical and pelvic examination, and she had a wall smear annually, but then that's again subjective. And then imaging sometimes, because she already had extensive nodal disease, so we had to do some scans to see about the pelvic nodes, which would, or any extensive metastasis to the upper abdominal nodes. So for that, we can do imaging also as clinically indicated and available.
Thank you. This is the new FIGO staging of 2021. There are slight changes when we compare it to the older FIGO staging for cancer cervix. These changes have been done in view of the Kaplan-Meier overall survival curves, which show that there is a clear separation between stages and substages, and that there is a much better survival when the depth of penetration, the depth of invasion, stromal invasion, is less than a millimeter. And we don't expect any nodal metastasis when the depth of stromal invasion is less than mm. I call on Dr. Amita to tell us something about why this new FIGO staging was required and what are the changes that are there in the new staging.
So one thing, the last staging was very confusing, and I think we can just forget. So remember the current staging, if at all. The basic purpose of this imaging is should, show the prognosis and have uniform language across. Now, important changes, as you rightly mentioned about depth of invasion, how we measure it. I mean, we, in the sense pathologists measure it, that has been changed. So we have to now measure it. 1 millimeter is from the deepest reti ridge to the deepest point of invasion. So that's one. So essentially there are 4 stages. Stage 1 is when disease is confined to the vulva. Within 1, we have 1A1 and 1A, 1A and 1B, sorry. 1A is when tumor is 2 centimeter or less and depth of invasion is up to a millimeter. 1B is when tumor confined to vulva but more than 2 centimeter. Now, 2 is involvement of, as in our patient, lower third of either urethra or vagina or anal. When nodes are involved, that becomes stage 3. So within 3, we have A, B, C. 3A is involvement. It has combination. I mean, it can be either lymph node or involvement of upper 2/3 of vagina or urethra or bladder or rectum or nodes. But nodes, if positive, should be less than 5 millimeter, up to 5 millimeter. 3B is nodes which are more than 5 millimeter, and 3C is essentially if there are nodes with extra capsular extension. So these are essentially, these are diagnosed on pathology. And stage 4A is if either primary tumor or lymph nodes are fixed, ulcerated, and 4B is distant metastasis. And I think we can forget this because this was so confusing. Now, some important highlight, this is for the first time, in fact, while doing staging, Data is first analyzed, a large cohort of patient, more than 12,000. They analyzed, looked at their survival, and then allocated stages. Rather, doing staging first and then looking how they perform. So all these sub stages are based on retrospective analysis of survival. The other important thing is now, like cervical cancer staging, imaging has the ability to change the stage. Like, lymph nodes can be picked up on imaging as well. Also, P16, which we just discussed, it is recommended to do IHC P16 to know whether these are HPV independent or HPV associated. So these are some of the things. But the thing is, it's a more simple and validated staging. And also important to remember, now we are doing sentinel lymph node biopsy, and many times pathologists may report what is known as individual tumor cell, but that does not change the staging. So that's not considered as lymph node metastasis. These are some of the points I think we need to remember.
Okay, thank you, Dr. Amita. We come on to our case 6. She's a 40-year female. Para 4 with last childbirth 8 years back. She had cancer of the clitoris, which was treated by radiation 3 years back. And now she's presented with a 3 into 3 centimeter growth involving the left labia majora posteriorly. The lower vaginal extension is also there. And the growth is about 0.5 centimeter away from the external urethral meatus. There are no significant inguinal nodes which are palpable. So what would be the management plan in such a patient regarding investigation, as well as what would be her
imaging? Of course, biopsy, I guess we need to confirm the biopsy, and imaging, either a CECT should be good, but we have to tell radiologists to look for groins specifically. And then plan could be looking at the thing. I think it's away from the urethra. So it's close to urethra, but not involving upper part of urethra. So radical vulvectomy with bilateral GND, because it's a midline lesion. And also she has already received radiation for clitoral malignancy. So I think re-radiation immediately will not be a good idea. Surgery will be a preferred modality of treatment here.
Thank you, Dr. Amita. So what counseling was done? We've already got this. We told her about resection of clitoris, urethral conservation, sexual function. We counseled her about urinary continence, any wound breakdown and lymphedema, and then took her for surgery. We want to talk about her groin lymph nodes. Both the superficial and deep have to be removed. Dr. Atul, what can you tell us about groin dissection in vulval cancer?
Basically, the groin dissection is a limited dissection in the vulvar cancer. If the groin is N0 clinically on the radiologically, then those cases and the lesion is T1 and T2, early T2, we have to go for sentinel lymph node biopsy. And sentinel lymph node biopsy is basically, it is the first training lymph node of a tumor. So if we can pick up that and send it for the histopathology and it is negative, then we can omit the superficial or deep inguinofemoral lymph node dissection. But if the facility is not available or person is not trained, in those cases, then we have to do a limited inguinofemoral lymph node dissection. We have to take the all superficial and deep lymph node along the femoral vein. Basically, it is the superficial to cribriform fascia and deep to it. And because the drainage of the vulva is limited to a medial to femoral artery, and it is just at the fossa ovalis. So basically, we have to dissect the area which is limited, is medial to femoral artery and medial to it, and along the fossa ovalis and at the inguinal ligament. So if we dissecting this area, it is a comprehensive lymph node dissection, and we have to open the cribriform fascia and the opening of saphenous vein. And saphenous vein should be preserved in all the cases until there is heavy nodal disease.
Thank you. I would also like to know something about the sentinel node that Dr. Atul has already mentioned, Dr. Bhagalakshmi. What is this sentinel node mapping?
Yeah, as Dr. Atul has already mentioned that this is the first group of to get the cancer. So the way how to know is that we inject a dye. It could be ICG or it could be methylene blue or isosulfan blue. It is injected on the advancing edges of the cancer, and the nodes are which usually take up the stent are removed and sent for frozen biopsy. And if the biopsy is negative, then you can do away with the lymphadenectomy. But then we have to remember that we have to validate this procedure very well in our center. Number two, it has a risk of false negativity. And in spite of sentinel node being negative, there is also a very rare chance though of nodal recurrence happening again. So I think before doing a sentinel node, we have to counsel the patient, take their consent. And if they agree to take the risk, then we can go ahead and do the sentinel node. And in case everything is fine, we go ahead with the sentinel lymph node. Still, we have to follow up these undissected groins very regularly because there is a risk of nodal recurrence in these patients. And the purpose of doing the sentinel lymph node is to avoid lymphadenectomy and to avoid the complications arising from lymphadenectomy, like especially lymphedema.
So nowadays, you would say that is the standard of care for early stage disease that is less than 4 centimeter tumor size with clinically negative groins.
Yeah.
This groins 7 confirms what we've already said. So what would be the complications of doing a surgery that is like a radical vulvectomy with groin dissection?
Yes, I think the biggest concern was wound breakdown, but that as we have really evolved and the technology has changed and all the electrosurgical devices evolving and more advances in technology, the wound breakdown rates have really come down, and scarring and narrowing of the introitus. So by using flaps, you can prevent the scarring and narrowing of the introitus, especially in the women in the reproductive age groups. But then even after this vulval surgery, and especially even the lesions which are very near to the urethra, if they have not been managed properly, urinary problems can happen. So, and sometimes it becomes really a problem. And sometimes if you have lesions more posteriorly, or you have not apposed them properly, sometimes prolapse symptoms including a rectocele can happen. And of course, lymphocyst formation is quite common in spite of using drains. Still it happens and has to be managed accordingly. And then the long-term complications, lymphedema. So the best way is by preventing them as an early diagnosis and prevention by giving some kind of massage, physiotherapy started very early, counseling them not to have prolonged standing and all those things. And early diagnosis and early management is the crux of preventing. It's not like preventing, but we can reduce the rate of lymphedema, because if you allow lymphedema to progress, I think it will become really very difficult. And so minor wound breakdowns may happen like this, but then if you know how to handle them properly, I think the rates have really gone down. So minimum tissue handling, minimum hemorrhage, and minimum use of hooks, and minimum leaving behind the fatty tissue behind and not destroying the fatty tissue. I think all those things, little things taken care of, really prevents wound breakdown.
Thank you, Dr. Bhagalakshmi. Going on to Dr. Amita, can you tell us something? We've already talked of the sentinel node. You know, what are the changing concepts for groin node dissection nowadays? Just a few guidelines.
The overall management of vulvar cancer, you know, if you classically, we used to read that butterfly kind of thing has absolutely gone, and it is more individualized. Based on the individual cases, and I am more conservative. So we just, you know, I just discussed that if it's a 1A disease that's less than a millimeter of stromal invasion, the risk of nodal metastasis is extremely low. So in these patients, we can avoid lymph node dissection at all unless nodes are enlarged. If it is less than 4 centimeter unifocal lesion, sentinel lymph node can be practiced, but as Dr. Bhagia said, you have to standardize it before making it routine, because we can't take the risk of missing out lymph nodes. That's absolutely fatal, and salvage rates are very poor. So we don't want to miss out on positive nodes. Now, if it is a lateral lesion that is a centimeter away from the midline on either side, then ipsilateral groin dissection is done first. If ipsilateral nodes are negative, contralateral is not required. However, if it's a midline lesion or if ipsilateral nodes are positive, then bilateral GND is done. And unlike, penile cancer, where if pelvic nodes are done, if groin nodes are positive, in vulva there is a study which has shown that doing pelvic lymph nodes, I'm not talking about inguinofemoral, pelvic lymph nodes, that is iliac lymph nodes, is not recommended. If iliac nodes are positive, we treat them with radiation, with chemotherapy, concurrent chemoradiation. So that's the basic philosophy of groin management in case of vulvar cancer.
Again, comment, a very stupid comment, that if the groin lymph nodes are not involved, we don't think the pelvic lymph nodes would be involved.
No, even if groin nodes are involved, we do not do pelvic lymphadenectomy.
Okay.
Even pelvic, groin and pelvic both are involved then also, and if nodes are enlarged and positively involved, we just debulk. Then a formal GND is not recommended, because these patients anyway would require chemoradiation, and the morbidity is very high if we do a complete groin node dissection and then give radiation. So if nodes are obviously metastatic, enlarged, we just debulk them. Groin nodes. Pelvic nodes are not.
Pelvic node dissection, no.
Madam,
if they are involved, we go in for CCRT.
Dear panelists, all of you are so learned, and I feel I'm in another era, place where high-fi things are being discussed. But we have finished 1 hour of oncology discussion, so maybe in another 15 minutes, you please wind up.
Yes, Dr. Shobna, we'll be winding up. We'll be winding up very soon. I'm so sorry that we're taking extra time.
No, it's okay. 1 hour is okay, but then if there is
we'll be winding up in the next 15
minutes, maybe you will have to speed up. That's all I'm saying.
Dr. Atul, what about the DVT prophylaxis in this patient?
Basically, if the lesion is small and we have done a partial vulvectomy, probably it is not required. But once we are doing the inguinal lymph node dissection or the radical vulvectomy for the large lesion, and all my practice, I prefer a DVT prophylaxis for all the patient.
Using some form of LMWH?
Basically, it is a dual mode. One is the mechanical prophylaxis during the operating hours. We use the compression devices, and after the surgery, we use the low molecular weight heparin, and which is continued till the time patient is mobile, generally 5 to 7 days.
Thank you, Dr. Atul. So histology was squamous cell carcinoma, well differentiating, margins were negative, base was negative, nodes showed only reactive hyperplasia. Dr. Gaurav, any role of adjuvant treatment?
Ma'am, no need of any adjuvant treatment. Margins are negative, lymph nodes are negative, a good prognostic factor. So patient can be kept on follow-up, and patient have already received radiation earlier, 3 years back. So no gain.
Okay.
Patient should be kept only on follow-up.
Thank you, doctor. Follow-up we already have done in the first case. So the same type of follow-up is required here also, lifelong follow-up. We come to our last case. And this is interesting because it's a case from Sultania Zanana, Bhopal. She was aged 75 years, married, para 5. She complained of recurrent vulval growth with diarrhea with mucus and blood. She had an excisional vulval biopsy 6 months back at a district hospital, which showed hair adenoma papilliferum. When she came to us, she had multiple pedunculated papilliferous growths over mons pubis, upper labia, which spread to lower vagina and anal canal. On pervaginal, the lower vagina on the left and posterior wall was indurated hard. Uterus was multiparous, no adnexal masses. PR showed perianal proliferative growth involving anterior left wall, which bled on touch, and the anorectal ring was also involved. Proctoscopy showed a proliferative growth, active bleeding, multiple lesions with extended 6 centimeter into anal canal. So obviously, the primary growth had been missed, and the biopsy confirmed that it was a primary anal papillary mucus adenocarcinoma with secondary metastasis to mons pubis. Now, this was nearly 25 years back, and the only imaging that was done was an ultrasound on her. My question to the esteemed panelist first is Dr. Amita, that in the current scenario, what investigation should have been done on this patient? Dr. Amita? Do I have Dr. Amita?
Yeah, so am I audible?
Yes.
Okay, so a colonoscopy, maybe a PET CT scan or CT scan of abdomen, pelvis, and thorax, and also cystoscopy. I think it's anteriorly also.
Okay. Dr. Atul, what about the surgical management on this patient?
I want to add one more thing regarding the investigation, because this was missed initially. So I would add, because this type of lesion, when they are multifocal, we are not aware which side is the origin. In those cases, we do the ISC, and ISC will tell us that this is a primary tumor of the anal canal or anal carcinoma rather than it is from the vulva. So this is the one thing. And this is basically it is a metastatic disease. Once the anal canal is spread gone to mons pubis and the subcutaneous deposit, it is a metastatic disease. So for metastatic disease, the best treatment is the palliative chemotherapy. And it's very selected cases. For the palliation, we may do surgery. For the if it is a causing pain or ulceration or some difficulties in the lifestyle. Otherwise, surgery has no role for the metastatic disease.
So the role is of Dr. Gaurav just now. Dr. Gaurav, how would you manage this patient?
Ma'am, she is an elderly female. I doubt that she would be able to tolerate chemotherapy and no surgery. Then I would like to give palliative radiotherapy with intent of palliation.
Okay, thank you so much. I think that should conclude our today's session on cancer vulva. And we've got this nice algorithm, good prognosis in stage 1A, where the only treatment would be a radical local excision. We become very conservative. No butterfly incisions anymore. In stage 1B and stage 2, go in for a modified radical vulvectomy, that also by 3 incision technique with a unilateral or bilateral lymphadenectomy. If the margins are close or positive, you may do re-excision. If the lymph nodes are positive or there is extracapsular spread, there comes in the need for adjuvant radiotherapy. In stage 3 and stage 4, the treatment should be individualized. If the lymph nodes are resectable, go in for a bladder resectable. You look for bladder and rectum involvement. If it's not there, then you will do a bilateral vulvectomy with, radical vulvectomy with bilateral lymph node groin dissection. If the lymph nodes are fixed and ulcerative, then you would think of the chemoradiation. Thank you, panelists. Does anybody want to add any more to today's session? My panelists, first both the gynec oncologist, then the surgical oncologist, then the radiation oncologist, and finally my 3 gynecologists if they are still here.
So thank you very much for the invitation, and it was very nice collection of cases, a variety of cases, and I think you covered the topic so beautifully. Thank you for a brilliant moderation.
For for most of the cases, I think we have to thank Dr. Bhagyalakshmi.
Right. So thank you, Bhagya.
Thank you so much. Thank you, Dr. Madhuri, for this nice panel.
Would you all like to add anything to the panel?
I think we have discussed everything, but the only thing I would appeal to all our gynecologist friends here that there's sometimes a real delay from their side. So I think we have to be a little more careful, because sometimes delays from the patient side, but sometimes it's also delayed from the doctor side. So I think if they delay, it's little different, but there should not be any delay in diagnosis of these lesions, and they come to us in advanced stages. So in case there is any doubt, I think we should not shy away from doing a biopsy and referring the patients early.
Dr. Atul, Dr. Gaurav.
Yeah, ma'am, very good session, and you have conducted very well. Only one point to add, that whenever there is slightest of suspicion, the gynecologist should do a biopsy. And that is the thing when Dr. Bhaglakshmi has also mentioned, that even with the slightest doubt, I have seen some patients referred to us after a long time treating conservatively. So whenever in doubt, and the biopsy should be from the good histopathologist. Sometimes the biopsy is sent to a general pathologist and they are reporting like lichen sclerosis, hyperkeratosis, that type of pathology. So I think whenever in doubt, slightest doubt, send the histopathology to or the biopsy to a proper pathologist or good histopathologist who can report properly.
Thank you. Dr. Gaurav, any comments?
I would like to say now it's a multimodality treatment. All of us should sit together and decide the treatment plan, as the last slide truly says. So for all malignancies, a multimodality approach should be used in present era.
Thank you. Like a tumor board. My gynecologist, Dr. Shashi, Dr. Shraddha, Dr. Meeta, any more comments?
No, you have done wonderful job. So I think we have a learned panelist and we are enlightened by them. Thank you.
Thank you all. And Dr. Shobna, thank you for sparing us a little
Can you
bit
put
more
up
time.
the screen sharing, madam?
Okay.
Thank you, Dr. Shobna. It was very nice hearing to you. Your
I don't know how I don't think you should be thanking me. I should be thanking you. My God, I didn't know so many cases existed of vulval cancer. Why Orissa is so full of vulval cancers? And how does Dr. Madhuri have contact with so many learned people? I think it's very difficult to find such a big August panel together. You have collected. That's also great. And collection of panelists is also good. Collection of cases is extremely good. All collections are good in this panel. So
thank you, ma'am.
Very small after hearing to that exciting panel.
Thank you, everyone. And Dr. Madhuri Chandra has taken the discussion to another level. And I'm really, my just last comment is that I'm basically an infertility person. So all the time I was thinking that we are now considering the transvaginal probe as our examining finger. So many times we just don't examine the patient. We don't inspect her vulva. We don't inspect her perineum, and she has been complaining of itching. And she's in her 30s and 40s, So this makes us imperative upon us to at least examine the patient and not forego the, visual inspection of the vulva. Thank you so much. And for
investing on a
they don't allow
very,
biopsies.
very
I've seen patients like this. They don't allow biopsy. When at the minute I tell I need a biopsy, they run away. That's another problem.
True.
They don't understand.
True, ma'am, very true. Sometimes it is the patient who's reluctant, but then it's again important that how we convince them and how we counsel and how we make our examining room so comfortable and so, comfortable for the patient to be able to be, in our midst and not feel harrowed by it all. Thank you so much. And for concluding remarks and vote of thanks, I invite Secretary Bhopal Menopause Society, Dr. Shraddha Agarwal, please.
Madam, would you keep it like to keep it open for anybody from the audience, whoever wants to comment? I don't think anybody can comment after this panel, but routinely we have to ask that.
Definitely. As Master of Ceremony, I would invite all comments, all queries at the conclusion of this session, which is 1 in 1,000. I feel so many webinars on so many subjects, but this is a topic which is touched very rarely. So any questions on vulvodynia, on fungal infections, on other chronic vulval disorders, and on cancerous and precancerous lesions, please be free, because we'll not get so many impressive personalities who are masters of this field all in one forum. We'll never be able to get this.
I think it's late in the night, so no question.
we'll
On
continue.
behalf of Bhopal Menopause Society, I am glad to be here to express my vote of thanks. Very special thanks to Indian Menopause Society, our learned president Dr. Shobna Mohandas, secretary Dr. Anju Soni, for giving us opportunity to host webinar on vulval diseases. With appreciating ideas, I mention my sincere sense of gratitude to all the esteemed speakers, chairpersons for enlightening us. Thank you for taking out time for the webinar. I must thank all the participants for their active participation. And lastly, thank you, Clarinet, our digital partner, for making this webinar possible. Thank you, everyone. Thank you.
Okay. I think with that, we'll say goodbye, and all of you can please come over to Calicut for IMSCON 2023 open invitation in February 16, 17, 18. Annual conference is there in Calicut. And meet you all on Sunday for the exercise, and next week we meet in Raipur on urogynecology. Good night.
Thank you, Dr. Shobna. We'll be there. We'll be there.
Thank you so much. Thank you so much, Dr. Shobna.
Okay,
Thank you, Shashi ma'am.
Dr. Shobna.
Yeah, thank you, Bhopal IMS. It was really a pleasure.
Thank you.
Bhopal has done a great job.
Thank you, madam.
Thank you and good night, everyone.
Thank you all. We're closing here. Good night.